This conference will now be recorded.
Hello everyone, welcome back again to the MRCOG online sessions. This is Dr. Kubara, and today I'll be joining you today to discuss the basics and concepts of the biostatistics for the purposes of the exam. Are you ready to go? Okay. So today we will be solving questions, then we will be explaining the important concepts and topics and the confusing points for those questions. You should today have, a level of understanding of the statistics, or you already solved some questions. But we will scratch the surface today. So are you ready to go? You ready to go? Tell me. Okay, good. So the sound is good, yeah? Good. Okay, so question number one, please. So you can write in the chat box. We're trying to find the relation of HPV infection and cervical cancer. Yeah. You proved that there's no significant difference in the rate of cervical cancer between women with HPV infection and those without it. Okay. This was proved to be wrong later on by another more accurate study. What kind of error your study has encountered? Can you write in the chat box, please, which answer is wrong, which answer, is the correct answer for this question? This is a typical exam style question. Hello, can you hear me? Yeah, D. Okay, we'll be waiting for some other colleagues as well. So what do you think, guys? What did you do? What did we do here? We did a mistake, didn't we? Yeah, we did a mistake. Okay, so let's see the correct answer. So you proved that there is no relation between cervical cancer and HPV infection. For that reason, you choose to accept the null hypothesis. This was proven to be wrong. Accepting the false null hypothesis. Is it type 1 or type 2? Accepting the false null hypothesis.
Type 2.
Type 2 error, yeah? Type 2 error. Is it a false positive or false negative result?
False negative.
False negative. So the correct answer would be D. Correct. That will be the correct answer. So let's just, recap this in a minute. So the null hypothesis, the hypothesis that states that no difference between the groups, that everything is negative, that the difference that you saw is a fake difference, that everything is equal, no difference at all, just by chance. Yes, Dr. Ziep, just by chance. So this is the null hypothesis. You can, compare group A to group B, like in the case of HPV infection and no HPV infection, to the rate of cervical cancer in group A and group B, and the null hypothesis states that there will be no difference at all between group A and group B and the rate of cervical cancer. That's one condition. Another rare condition that can be used, and actually it comes in the exam frequently. You might have one group, just one group of patients, and you need to do a null hypothesis. How can we do a test with just one group? Yeah, you can set a predefined value. Yeah, you can set a predefined value. I'll tell you what I mean by that. Like if you need to prove that a mean weight for the patient should be more than 80, for example. So now you set a value, an 80, yeah, and now you need to prove that this group is more than 80. More than 80, for example. So you predefined a value in 80, yeah? And now you need to test whether your group is equal to this value, less than this value, or more than this value. The null hypothesis would state that your group is equal to that predefined value. Okay? So sometimes it does come in the exam like this, like in that scenario, okay? And we'll be using the p-value to accept or reject the null hypothesis. How is that? If the p-value is equal to or more than 5%, that means that the level of a chance is so high, level of a chance, level of fake differences, level that what you saw in the difference with just a look, with just a chance, that's not real difference. We do have a cut of 5%. Okay, Dr. Fass, you didn't get which point exactly? Could you please open your mic and tell me which point that you didn't get, so I can repeat it for you. So basically, just bear with me for a second, please. The null hypothesis stated that there's no difference between the groups. If I told you that we have 100 women and 100 men, okay? And we need to compare both groups together. Yeah, I'm repeating that. We need to compare both groups together. Like we have 100 female students and 100 male students, okay? I'm stating that the null hypothesis will tell you that both groups are the same, let us say, in the scores, for example, okay? They do get similar scores. They both the students, both males and females, are equal in the cleverness. They are both clever, okay? That's basically the null hypothesis would tell you that no difference in the scores between males and females, okay? You did some tests, and out of that test, every test that we do in statistics, like the t-test, the chi-square test, the odds ratio, everything we do in statistics will bring you in the end a p-value, okay? So at the end of the day, after we did the test, okay, you will get a p-value in the end. The p-value will tell you if that difference between the groups is equal or not equal. Is it real difference or a fake difference? Whether to accept the null hypothesis that both groups are similar, or they are really different, or that really female students are better than male students. Either the HPV infected women really they have more risk of cancer than the non-HPV infected women. If the p-value is high what? High, above what? Above 5%, 0.05. So if it is equal to 0.05 or more, like 6%, 7% or so, in that case, we accept the null hypothesis. The level of a chance, level of error is so high, and we assume that both groups are similar to each other. Is that clear, Dr. Fass? Please tell me that. Is this clear, Dr. Fass? Okay. And the same. So we did a comparison between group A and group. You're welcome. We did a comparison between group A and group B. And we also can make a comparison between one group and a predefined value. Okay, I'll show what I mean in a minute. Just be with me. So in the errors, we have two types of errors. What do I mean by error? An error means that we did something wrong. As I told you that if the p-value is 5 or more, we tend to accept the null hypothesis. Is that correct? And if it's less than 5%, like if it is like 4%, 0.04, if it's 1%, like 0.01, okay, we reject the null hypothesis and accept the alternative hypothesis and accept that there was a true difference between both groups. Okay, so we might do something right and we might do something wrong, okay? By doing something right, I mean by that you accept a true null hypothesis, okay? you accept something true, you did the right thing. If you reject something false, you did the right thing. The error occurs if you accept something false, you reject something true. Is that correct, guys? Is that correct? All we care about is the null hypothesis. So null hypothesis can be true, null hypothesis can be false, okay? If we accept a true null hypothesis, we did the right thing. If we accept a false null hypothesis, we did the right thing. We did a very bad thing. Is that clear, guys? Okay. So how we said that how to choose between, whether to accept or reject the hypothesis using the p-value. But I didn't tell you how the null hypothesis could be true or could be wrong. Okay, this is not our job today. This is we know that from the literature, from the other more accurate studies, from other textbooks, from other literature that will tell us that really HPV infected women are at high risk of getting cancer. I think every one of you knows that. Is that correct, guys? We know that HPV infected women, are at high risk of getting cancer. Yeah, that's correct. But in our research, in the previous example, we didn't conclude that. We concluded that HPV has nothing to do with cervical cancer. So we did something incorrect. We did something, we should have done that. We accepted a null hypothesis that was false. So here we do have an error. Okay, we have type 1 error and type 2 errors. Bear with me for a second, please. Type 1 error is the false positive. Type 2 is the false negative. What do I mean by that? False negative and false positive. This is in reference to the null hypothesis. False, let's start with type 2 first. Type 2 is much more important than type 1. Okay, type 2 is very important and very dangerous. Okay, type 2 is a false negative. That's we accepted the false null hypothesis. The null hypothesis was false. The null hypothesis means the negative hypothesis. So we accepted the false negative thing. This is the false negative. It's more dangerous. I'll tell you why it's more dangerous in a second, but let's just compare it with the type 1. Type 1 means the false positive. Yes, because yeah, that's correct. So type 1 false positive. What do I mean by false positive? That we like take this for an example. You're doing research about hypertension and endometrial cancer. Yeah. In your group, you have 100 women with hypertension, 100 women without hypertension. At the end of the day, you figure out that the rate of endometrial cancer in women with hypertension is so high, it's much more higher than women without hypertension. And the p-value is significant. By significant, I mean it's like 1%, less than 5%. Let's say it's 1%. So based on the p-value, I think that there is a real difference between women with hypertension and no hypertension, okay? And based on that, I reject the null hypothesis. I reject the negative hypothesis. I rejected the hypothesis that says both are the same because they're not the same based on my research, okay? Are you with me, guys? Stay with me. Is that clear to that point? So what I did wrong now, what I did now, I rejected the null hypothesis. Do you know from your reading, from your experience, from the literature, from other studies, that hypertension has nothing to do at all with endometrial cancer? Yeah, and both groups should be the same thing, but we didn't do that. We didn't conclude that in our research. We, for some reason, proved that hypertension has something to do with the endometrial cancer, and based on that, we rejected the null hypothesis. We rejected the negative hypothesis. So we did a type 1 error in that. Okay, which one is more dangerous, type 2 or type 1?
Type 2.
Type 2 is much more dangerous. Type 2 is very dangerous. I told you, it's like releasing a criminal in the street. Take a look at that. This will save your life in your exam, because in the exam you'll never be able to remember all that details. A false null hypothesis is like a devil. If you accept a false null hypothesis, you're just shaking hands with the devil. That's very dangerous. Okay? This will remind you in the exam that if you accept a false null hypothesis, you did type 2. Type 2, 2 or B2, the bigger number. Yeah, 2 is bigger than 1. Yeah, so type 2 is much, disease, leaving a disease without any treatment. You'll kill the patient. If you conclude that women with HPV infection are at no increased risk of cancer, so next time if you implement that in your clinical research and clinical practice, next time if you see a lady with HPV infection, you'll send her home. Yeah, and you just kill the patient. Do you know what I mean? So false null hypothesis is like a devil. If you accept a false null hypothesis, you're just shaking hands with the devil. This is a very bad mistake. You shouldn't do that at all. Okay, guys, is that clear? So just remember that type 2 is the bigger mistake. Type 2 is the bigger mistake. It's accepting a false null hypothesis. Accept you did a false negative result. Okay, good. I know, this takes time to absorb, but hopefully with the questions, everything will be clear. This is just for you. It doesn't come in the exam a lot, but sometimes it appears in the exam, turn up in the exam. So errors in sample size calculation. Of course, we all know that there are no studies without errors. Okay, so there must be some degree of error, and it's you, the researcher, who defined what level of error should be the maximum. You shouldn't be doing the probability of type A or type B error. There should be a cutoff. This cutoff is very important for you to remember, because sometimes it does come in the exam. Okay. I'll explain that in a minute or two. Let's finish with those questions first, and we will go back to the strategy questions. So no studies without errors. Okay, the predefined maximum probability of errors used to calculate the target power of the study should be like this. Type A error shouldn't be more than 5%. Type B error shouldn't be more than 20%. Okay. The power of the study is 1 minus B, which is like 100 minus 20, should be 80%. 80%. Okay, so type A is 5%. You just need to memorize those numbers, because in the exam, sometimes they do come in the exam. Okay, so the maximum probability, the maximum level of type A error, 5%. Type B error, 20%. The power is 100 minus B, or 1 minus the inverse of type B. So 1 minus B is 80%. Yeah, is that correct? And there's some certain equations that you plug in those numbers and complex equations. At the end, you get the sample size. You get the required sample size. The sample size that will achieve this maximum probability of errors. Okay, if you collect patients less than that, the study will be underpowered. This will be a weak study, if you know what I mean. Are you still with me, guys? I'm just, I know statistics is very difficult for, physicians, but I'll try, crack it a little bit for you. Are you still with me? Do you think I'm talking too fast, or, jumping things?
No problem, sir. It's okay.
Is everything clear? Okay.
Yes,
okay,
sir.
Thank you, Tazim. Thank you so much. So those are the numbers that you need to know. Type A, 5%, type B, 20%, the power of the study 1 minus B, which is 80%. Okay. So now you know how to calculate the power of the study and how to calculate the sample size. Okay, every study design has a unique equation, tailored for the design to calculate the sample size. You don't need to know at all to know anything about it. Okay, you just need to know that we take those numbers, plug into the equations to get the sample size. Like say, for example, the sample size required for a certain study is 100 women. 100 women. Okay, Dr. Bob, 100 women. If we collect 100 women or more than 100 women, we will be achieving our desired type A error, type B error, and the power of the study will be 80% or more than that. Okay, if we collect like 50 women, no, the power this will lead to a much higher probability for type B. Type B error will be like 30 to 50%, for example, and the power will be less than 80%. Will be like 70 or 6 underpowered. Yes, of course, will be underpowered study. Okay, next. Question 2. So the null hypothesis sometimes is, abbreviated as H0 when compared to means shall be interpreted as all except. So tell me, so the null hypothesis when comparing two means shall be interpreted as all except. A, data not supports the hypothesis that population means are different, or compared values are different, the two sampling averages don't differ significantly, or the two populations from which compared values were sampled don't differ. Which one is the correct answer, guys? The compared values are different. Okay, D. So guys, remember please that everything is correct except. So we're talking about the incorrect answer actually. Okay, which one is incorrect? So think again. The correct answer would be B, correct. You need to, read the leading of the question properly, guys, because here is the trick. Except, yeah, the null hypothesis, sometimes if you're confused about the word null hypothesis, yes, Dr. Zia, if you're confused about the word null hypothesis, you can strike it off in your mind and put the word negative instead. This is not, perfectly accurate, but it works, So the negative hypothesis, when comparing two means, shall be interpreted as all except, that don't support hypothesis that population means are different. No, this is incorrect. This is correct. Yeah, this is correct. But we're talking about the incorrect values. Compared values are different. No, the correct values are not different. So this is the incorrect answer. This is what we should choose in the exam. Okay, guys, are you clear to this point?
Sir, does that mean that all the other options are actually indicating the same thing and the B option is not?
So choice number A, choice number C, choice number D are all the same thing, or are correct about
all the same thing, right? Yeah.
About the interpretation of the null hypothesis. Your choice number B, the compared values are different, is incorrect. The null hypothesis states that the compared values are not different, or differ insignificantly, or no significant difference between the group. But B tells you that the compared values are different, which is incorrect. So this should be our choice because we are talking about the except here. Okay, Dr. Baba.
Thank you.
Okay, next we have 20 questions today, guys. So we need to be, a little bit quicker than that. Okay, question 3. You're welcome. Which of the following is true? As you can see from the questions, actually in the exam, there's so many questions about the null hypothesis and the alternative hypothesis. Back in my exam in, January 2021, this year, the first question in the first paper was about the null hypothesis. Okay, so you need to study that. You need to have a clear concept of that in your mind. Okay, so which one is true? Okay. Type 1 error occurs when the null hypothesis is rejected. is actually true. Type 2 occurs when the null hypothesis is accepted. What is it actually false? Part of the study, the inverse type of type 2 error. Okay, level considered acceptable for type 1 error rate is 5%. So as I told you, did you see number D? So it's talking about here, about what? About the cutoff for type 1 error, which is 5%. Wasn't the cutoff for type 2 error? The cutoff for type 2 error. The cutoff 20, perfect. And the, the minimum power of the study. Minimum power of the study, which is 1, yeah, 80%, perfect. So what do you think, guys, about the answer of this one? A, everything is correct.
E,
Yeah.
all of the above.
E, all of the above. Okay, is this question clear for you guys? Good. Next, with regarding to the hypothesis testing, which of the following is correct? Okay, so again, another example of the concept of the null hypothesis. So null hypothesis specifies a hypothesized real, you need to read this question properly. It's really a tricky one. This is really not, easy one to go, okay? So what's correct about the null hypothesis among those? Null hypothesis specifies real value for a parameter. Type 1 error occurs when the null hypothesis is not rejected when it is false. Type 2, when the null hypothesis is rejected when it is true. Okay, the power of the test is probability of accepting the null hypothesis when it is false. An alternative hypothesis specifies a real value for a parameter, which will be considered when the null hypothesis is not rejected. Okay, some people A, B, C. Okay, I'll show the answer. Unfortunately, I know this is a tricky question. Yeah, I know. I actually, me myself, I spent, much more time to think about it. No, the correct answer. Okay, 3, 2, 1. That's the correct answer. I know you have a lot of questions to ask in this one. Okay, but if you look me, so forget about the A. So let's take it from, down from bottom to the top, okay? An alternative hypothesis. Remember, we're looking for the correct answer, okay? Not the accepted. We're looking for the correct answer. Okay. An alternative hypothesis specifies a real value for a parameter which will be considered when the null hypothesis is not rejected. The first part of the sentence is correct. Tell this, an alternative hypothesis specifies a real value for a parameter which will be considered. Yes, till here, this is correct. But the second half of that sentence is incorrect. We don't consider the null hypothesis. When will be considered when the null hypothesis is not rejected. It should read like this. It should be considered when the null hypothesis is rejected. We do have two hypotheses. Yeah, don't we? Yeah, when rejected. We do have two hypotheses, the null and the alternative. We don't care about the alternative hypothesis at all. All we care about is the null hypothesis, the negative hypothesis. We will accept the null hypothesis or we will reject the null hypothesis based on the p-value. So if we accept the null hypothesis, then intuitively, as a sequely, we will reject the alternative. So the alternative always comes second to the null hypothesis. Depends what you do with the null hypothesis. If you accept the null hypothesis, then you reject the alternative hypothesis. And the other way around, if you reject the null hypothesis, then as a sequely, you will accept the alternative hypothesis. You know, this is something I know it's confusing, it's silly, I know, but this is the, you know, the philosophy of statistics. I know something really, you know, silly sometimes. So now we convinced that A is not correct. So D, the part of this test is the probability of accepting the null hypothesis when it is false. Obviously, this can't be true. Yeah, because we said that the power of the study is the ability of the study to do the correct thing, the ability of the study to avoid the error. Yeah, 80%, remember that. 80% the power of the study to do the right thing. So it can't be accepting something false. Okay, sir, please explain point E again. So point E, I told you that we do have two types of hypotheses. We have the alternative hypothesis and we do have the null hypothesis. Please stick with the null hypothesis. You start with the null hypothesis. If you reject the null, you will accept the alternative. Can you hear me, guys? Some people say that they can't hear me. Can you hear me, guys? Hello? Okay, good. So please, you check your connection again. Okay, thank you so much. So E is stuck with the null hypothesis. You reject the null, accept the alternative. You accept the null, you reject the alternative. You reject the null, you accept the alternative hypothesis. That's it. So if you read the question properly again, doctor, you figure out that this can't be true at all. D, the same thing can't be true. C, type 2 error occurs when the null hypothesis, okay, you're welcome. So type 2 error occurs when the null hypothesis is rejected when it is true. Is it type 2 or type 1? So basically, this is type 1 error, yeah, because you did a false positive result. False positive means type 1. You rejected the negative, so you did a positive thing, but that was a mistake. So that's a false positive thing. So you did a false positive result. Yeah, that's correct. That's correct. False positive. So basically, B and C, we mix things together. Yeah. So we left in type 1 error. No, it should be the false positive one. Okay, so we mix things together here. Should be this type 2, it should be type 1. But at the end of the day, B, C, D, A are all incorrect. So we're left with the first sentence. Null hypothesis, yeah, it's weird, you know, it's weird reading, you know, it's, the inscription is so confusing. Null hypothesis specifies a hypothesized real value for a parameter. What on earth does this mean? I'll get back to my previous slide. This one. Yeah, this one. So this is the uses of the null hypothesis. Forget about the green thing, focus on the orange thing. I told you in a minute that you can use the null hypothesis to specify if one group meets a predefined value or not. So the null hypothesis states here that your group, you know, is equal to the predefined value you specified, yeah, like 80 for the weight, or like 30 for the BMI, or the population mean. For example, if you have one group of women, like 1,000 lady with breast cancer, you need to figure out what's the mean age or the median age for breast cancer. Yeah. So let us say this is my theory. It should be like more than 50 years of age. To test that 50 years of age against my group, I need to use the null hypothesis. Okay. If there's p-value is correct, they'll be equal to each other. If the p-value is less than 5%, I reject the null hypothesis and the age is not equal to 50. So it's less commonly used, by the way, rarely used, but it does come in the exam. At this point, clear, guys? So to recap this point, You can use the null hypothesis to compare two groups to each other, or you can use it to compare one group to a predefined value. Okay, read that question again. Okay, that's clear now.
Hello, sir.
Yeah.
So may I ask a question related doubt? Sir,
Yeah,
if
go
all
ahead.
the previous established studies have said that there is a difference between two drugs, and our study says there is no difference. So
Yeah.
what type of error will our study have?
What do you think? What do you think, doctor? What do you think? Tell me what do you think?
Sir, I know it should be type 2, but I am not very sure of what is the null hypothesis in this scenario.
The null hypothesis, the negative one. This is perfect. You're correct. This is type 2 error. What do you think you did? You did a false negative thing or false positive thing? You study that you're doing.
We need to
Was it false?
consider our study with respect to the already established studies. So that's how we compare, is it?
No, the previous established studies are much more powerful, you know, are much more accurate. They're well established in the literature. So they must be correct and you must be wrong. This is how it works. You know, there's, so much details between this and that, but, for the purposes of that, I just need you to remind you of some certain concept that will help you in the exam. What kind of error did you do in that, your example? Was it a false positive or a false negative?
It was a false negative.
The devil. This is the devil. You accepted a false negative result. That's a devil. That's very bad. Okay?
Yeah, sir, also, I mean, the null hypothesis here is what the previous studies or our study. The previous studies, if that is considered as a null hypothesis, then there should, I mean, null hypothesis by definition is there is no difference between the study. That is,
I got your point. Just let me explain. Bear with me for a second. Thank you so much for the
okay.
question. The null hypothesis is everything you do in your study. It doesn't have anything to do at all with the other studies. The null hypothesis is in your study. The state of being it false or correct depends on the other studies, but you accept or reject the null hypothesis based on your study. Okay? Whether it's correct, correct null hypothesis or false null hypothesis, it depends on the other studies or some other things. But for the purpose of the exam,
So null hypothesis is something a reference from which we are drawing the conclusion. Am I right?
Yes, that's correct.
Okay, thank you, sir.
Okay, you're welcome. So let's just keep going, guys. 5. This is a very straightforward example of the null and alternative hypothesis. You're after performing a student t-test for comparison of means, we obtain a p-value of 0.0256, which is like 2%. Yeah. So what do you think? Tell me what you think, guys. Yeah. Study. So repeat that again, please. Study not different. Why? Why not different? The p-value is less than 5%. There must be some. Why not significant? Why not significant, Dr. Zia? That's significant. Is it more than 5% or less than 5%? Okay, if I put which one is 0.025 and 0.05. So this is less than that, yeah? This is less. This is less than 5%, yeah? So less than 5% means that we are very accurate. The chance of error is so low, yeah? Is that correct, guys? The chance of error, yeah, is very low. So we're basically saying that we are really sure about the results, and you, the null hypothesis, will reject what you're saying. So no null hypothesis today, and we will accept the alternative hypothesis because we see real difference, and that real difference is significant because the p-value is less than 5%. Is it clear, guys? That's a straightforward thing. More than 5%, you accept the null. Less than 5%, you reject the null. Basically, simple. Good. Good, 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 good. Next. So another set of things today. So we've done with the null hypothesis and the philosophy of statistics. Another question about the types of variables. We're collecting data about the effects of new medication on women with chronic pelvic pain. Women should describe the pain intensity in a visual analog scale. Buzz. What kind of a data in the visual analog scale? Ordinal. You know, it comes a little in the exam, yeah? The visual analog scale. What is this? So I'll need to show, this is the visual analog scale, if you haven't seen it before, okay? It's basically, you know, you got a scoring system like in the PMS or the anxiety scoring system. When you ask the patient, you know, actually this, you know, happens in real life every day in clinic in the NHS. Okay, you ask the patient, tell me about your mood today. Tell me about your anxiety today. Tell me about your pain from a scale from 0 to 10. 0 means no pain, the least thing at all, and 10 means something that's very, very high. Very high. This is a scaling system. If you're not familiar with the types of variable, I'll explain that in a minute, okay? Every scoring system you study, every scale you study is ordinal. Ordinal. So if you're not aware, if you're not familiar with the types of variables, this will explain everything to you. We have two types of variables. Something, oh, sorry, you know, I do live near a train station, you know, railway station. So it's a shame. I'm sorry about the noise. So let's just continue. Types of variables. So we have something, yeah, you can measure, you can count on the patient. Yeah, something you can measure or count on the patient. Those are the numerical variables, numbers, okay? We have two types of numerical variable, continuous and discrete. What do you mean by this? Like age is continuous variable, weight, continuous variable, expected fetal body weight, also continuous variable. Why is it called continuous? First, we all agree this is numbers, yeah? Yeah, first lady, age 60. Second lady, age 61. Third lady, age like 56 or so, okay? This is about the continuous variable. This is the numbers, yeah? Continuous variable means it can take any value. There's countless number of ages, countless number of ways. Age could be 61, 61.5, 62.8, 63.568. Yeah, is that correct? So it can take any value. So is the weight. So is the expected fetal weight. So that's the first group, continuous. The second group of the numerical variable is the discrete. The discrete, like the number of metastases. All of us studied the figure classification of the molar pregnancy, the invasive mode, yeah, GTD, I mean, gestation trophoblastic disorders, yeah, we all did that, yeah. So one of the staging system, the number of metastases, yeah. So this you can count on the patient. First lady, she got like 2 metastases. Second lady, just 1 metastasis. Third, so it can take just one integer. 1, 2, 3, 4. There's no such thing called 2.5. There is no such thing called 4.6. Like the parity. Lady could be para 1, para 2, para 3, para 4. There's nothing called para 2.5. Is that correct? Smoking status, I'll tell you the smoking status in a minute. But in this point, clear, guys. Do you know now the difference between the continuous and discrete variable? Okay. What about the groups, the categorical variables? This is a condition if it exists, it doesn't exist. I'll tell you what I mean in a second. Okay, let's take a very basic example of the categorical variable, like here in the middle, all the way down in the middle, male or female, or positive or negative, or white or not white. Okay, this is called categorical binary, or sometimes same thing, you know, don't be freaking out with the name. Sometimes they're called dichotomous. Dichotomous means binary, same thing, but it's just, you know, trying to complicate things. So binary means dichotomous, same thing, okay? You know, don't freak out, okay? So nominal with two possibilities. First lady, like a positive test. Second lady, negative HPV. Third lady, again, negative HPV. Third lady, positive HPV, same. So this is called categorical binary variable, okay? We have other type of categorical variable like the country of origin. First lady, she's from the UK. Second lady from the US. Third lady, like from Egypt. Third lady from India. Fourth lady from Mexico. Other thing, or ethnicities, black, white, Asian, mixed, Middle Eastern, sort of things, nominal, okay? Can you measure those things? Can you count on the patient? No, you can't count that on the patient. You assign the patient whether she's white, she's from the UK, she positive, she's negative, all things. So no reason for you to mix things with the numerical variable. Do you see what I mean, guys? Do you know what I mean? Please tell me you're still with me in the chat box. Good. Am I talking too fast? Good, thank you. The third, thank you, Dr. Dua, thank you. So the third one, which actually comes a lot in the exam, the ordinal, like the vase. What's the vase? The visual analog scale, as I told you. The cancer stage, any scoring system, so stage 1. So basically, the ordinal, same as the nominal, with ordered ranks. Something is better or higher or more severe than the other one. Yeah, something is more dangerous or less dangerous. Mild, moderate, severe, ordinal. Stage 1, stage 2, stage 3, ordinal. The VAS, the visual analog scale, because the 0 is less than 1, is less than 2, is less than 5, so and so. Cancer stage, same thing. Okay. I did that for you. I hope you studied that a lot. UpGar score, same thing. Thank you, Dr. Fadia. So, UpGar score, same thing. 0. I don't know much about the UpGar score. I'm sorry, but I know that any scoring system, ordinal. Don't, confuse yourself about it at all. Let's just take a trick on this. I need you to tell me age. Do you see the age? So I did that for you. This is like a real study, like a study with 10 cases, case 1, 2, 3, 4, all the way down to case 10. We're collecting data about the first lady, age, weight category, HPV status, cancer stage, country of birth, anxiety scale, number of metastases. So tell me age, which kind of data based on your understanding? Numerical continuous, perfect, continuous. Second, weight. What nominal? No, not nominal. Continuous again. It's because we doing weight here, yeah, continuous. So if I put a cutoff for the weight, like if I told you that above like 90, above 80 would be obese, and below 80 would be non-obese. So what kind of variable? Binary, perfect. Two categories, yeah, binary. So every time, this is a trick for you, by the way, sometimes it comes in the exam. If you need to transform from continuous variable to, binary, you need to set a cutoff. Like for the age, we say that above 50 is an old age, below 50 is in young age. So some ladies will be transformed from being continuous variable to binary variable. HPV status again will be binary. Cancer stage. So cancer stage would be stage, ordinal, country of birth, nominal, yeah, perfect, nominal, anxiety scale, nominal, scale, ordinal. Don't forget, scoring system, cancer stage, any scale you know in your life would be ordinal. Number of metastases, number, discrete. Perfect. You're actually aced it today, guys. Thank you so much for listening to me. Discrete, because we count on the patient. First lady, like in that case, case 1, she got 3 metastases. Case 2, she got 3. Case 5, she got 0. Discrete. Discrete means integers, like parity, like previous general sections. Okay. Good. Some questions about that? Cancer stage cannot be discrete. Yeah. This is a very good question. I'll show you in a minute, because they both got numbers. Can you count cancer stage in a patient? Like this patient got 2 cancers, or 3 cancers, or 4 cancers. Ratio is something else. I'll tell you about that in a minute, but don't have to confuse yourself. Yes, Dr. Zia, I just need you to clear the concept of the main thing that does come in the exam. I forgot to tell you that there's many other variables, in the real life of statistics. Well, I just selected the most important thing that comes a lot in the exam. Okay, just the first thing we need to do is to fix the concept, to clear the concept. Later on, we can study the odds, study the weird things. Okay, the ratio, the continuum, the scale, especially the temperatures or so. But for the purpose of the lecture today, you just think of age as a continuous variable, and this is correct, by the way. So cancer stage can be ordinal, categorical, and binary. Categorical, because here can be anything, can be 2 groups, could be 3 groups. Like, for example, if I have 3 groups of ethnicities, like white, black, and other, this is categorical variable, yeah? How many groups? 3 groups. We have white group, we have black group, we have mixed group, or other group. Binary means just 2 things in the group, like white, non-white, black, non-black, male, female, positive, negative. Do you see what I mean, Dr. Zia? Good, thank you. Now, cancer stage. This is, you're welcome. Cancer stage, ordinal, because stage 1, binary means smoking, non-smoking. Yeah, that's correct. Smoking, non-smoking is binary as well. Good. So for the cancer stage, could be, so stage 1 is less than a stage 2, is less than a stage 3. So the cancer stage, scale, scoring system, those are categories, but they're not all the same. Something is more severe than the other one. Like for smoking status, so what is that could be continuous? The question, I didn't get your question. Somebody's talking about the smoking, the continuous. No, stage is progressing. So yeah, this is the whole thing about, just one by one, guys. So this is the whole thing about the binary, the ordinal thing. It can progress from certain stage to another stage. This is why we call it an ordinal. It occurs in orders. Now, for example, suppose that you need to, study the effect of certain drug on the cancer stage, like neoadjuvant chemotherapy. Yeah, cancer stage is ordinal. Yeah, I'm sure about that 100%.
Dr. Ahmed, can I ask you?
Sorry, yeah.
Yeah, so my question, why it came in my mind is, when we talk about cancer staging, we also mentioned that there is something called as cancer stage 0, because there the 0 has got the value. So what I understand is, in discrete variable, like example, height, weight, temperature, everything has got the value.
No, you're confusing yourself. Just let me explain that in a minute. Forget about cancer 0. You can put that like cancer 0. That's the name, guys. So cancer stage 0. This is the name of a stage. This is not an actual 0. This is non-countable. Okay. So this is the name of a stage. You can call it in your mind like the lowest stage. Okay. Then stage 1 would be like again level 2, for example, and level 3 for stage 2, and it goes like that. Okay. So cancer stage 0 is a name. 0 is not 0 like 0 age or 0 weight or 0 length. Do you see what I mean? You're confusing yourself, guys, because you think that anything with 0 could be continuous. This is incorrect. 0 could be a name of a group, could be a name of somebody. Yeah? Do you see what I mean? Do you see what I mean? If I told you that we have two groups, group 1 or group 2. So we have group 1 and group 2. Can we add those together so we have group 3? This is absolutely incorrect. So this is the name of the group. You can put like group A here, group B here. Sometimes you have group 0. Yeah. For example, group 0. Can I say that since this group is called 0, can I say that this is a continuous variable? No. Still groups, still categories. Now you see what I mean?
Yeah.
Okay. Okay.
Thank
So, yeah, you're welcome, dear. So next question. We have 20 questions today, guys, and we will spend so much time today talking about the study design. This lecture today, actually, for study design. So cancer group is categorical. Cancer group, what do you mean by cancer group? What do you mean by cancer group? State. So this question. Okay, could you?
Nominal.
Yeah, carry on. Carry on, please. So open your mic and tell me what you think. What's your question? Country is nominal. Okay, so could you please open your mic? I have so many questions in the chat box, guys. Actually, like 1,000 tons of questions in the chat box. I don't know.
Sir, I have
Yeah.
only one query, that the previous point which you have discussed just now, that about the cancer stage. The cancer stage, let's say it's a cancer 1, 2, 3, 4. There are 4 groups, right? I mean, it's a kind of basically we divide the people into a 4 kind of. It's a categorical, like category 1, category 2, 3, or 4 types. So is it we label it as a categorical data? Like in the summary like that, because sometimes we confuse between the categorical data and non-categorical data. So is it a stage is a categorical data, because sometimes we have to apply the test further and we want to see, oh, it's a categorical non-categorical. So stage is always a categorical data, sir, then?
Yeah, categorical.
Yeah, thank you so much.
Everything
That's what I want to confirm that, sir. Because that, and also second thing, sir, which I want to confirm.
Okay, categorical of ordinal type.
Yeah.
Okay, I'll tell you why. You see what
because
I mean
this point is, sir, many times it's coming and it's creating us so much of the chaos that what exactly in a ordinal we take as a categorical data exactly.
Ordinal is categorical. Sure.
Yeah.
Ordinal is categorical. Ordinal, you know, get back to my previous. This one is very important for you. This is the thing that you need to remember, actually. So we hear ordinal onto categorical.
Categorical. So ordinal is always a category. Yeah, it's a one of the subgroup.
Yeah, mild motor. So cancer stage. If we have a stage 1, stage 2, stage 3, stage 4, and stage 0, for example. Sometimes I call this in situ, for example, in situ or in situ. Yeah, or locally malignant. Stage
that
1
is a part of that.
Sometimes we call it mild. Stage 2, sometimes we call it moderate. Stage 3, I may call it moderate to severe. Stage 4, I call it severe. Yeah, this is my, so for example, I'm not saying that this is accurate or correct. If I'll imagine that back in my university, this is the thing that we used to do in everyday cancer unit. We call 0 in situ, we call 1 mild, we call 2, we call 2 moderate, we call 3 moderate to severe, we call 4 severe. Okay, this is what we do.
Yes,
Categories.
exactly, sir. Thank you. And one more query, sir. Pardon, one more query, sir. Which you have just mentioned is a very nice point. So thank you for that. That the age is a continuous data, but when we divide the age as a subgroup, let's say our data says less than 40, 50, or more than 40. When we are comparison that, then it become binary kind of, because we are comparing in a 2, right, sir? And then at that point, it become a kind of a categorical data, because it is another subgroup of the categorical data, right, sir?
Yeah.
Please correct me, sir, if I understand something wrong.
Yeah, perfect. Just like we did here in the weights. If you take a look at the weights, yeah, we set a cutoff of 80. So this one obeys, this one obeys, this one obeys, this one, no, she's good. This one obeys, this, so and so and so and so. So we transformed weight
into 2.2 groups. Yeah.
That's what you need to do, guys.
Excuse
Thank
me,
you so much.
Excuse me, sir. I have one question.
Yeah,
excuse me, sir. I have one question.
Yes, carry on.
In the binary data, do we have to divide it in only 2 categories, like obese, non-obese, or can we categorize it into further?
Binary, again, I'm sorry for the train. Sorry about that. Binary means 2.
Yes,
just
so
2.
For that reason,
binary.
Only 2 groups are allowed?
2 groups. And ideally, let me just tell you, ideally, binary means yes or no. But
yes.
It can't, any 2 groups.
So we cannot, okay. So we cannot binary. Have more than 2 groups.
More than 2, this is just categorical variable. Like for example, like I have black, I have white, I have other people. This is just, this is of course, this is not binary at all. There's 3 categories, also 3 categories.
Yes.
Can't be binary. Binary actually it came from computer science 1 and 0s.
Thank you, sir.
So
right.
Yes or no?
Thank you so much.
Okay, guys, we need to run. We still have much more to cover today. So one of the data you collect in the country of birth, you said that would be nominal. Good. Next, one of the data you're collecting in the gender, male or female. Which one is this?
D. Pardon. Nominal.
In the chat box, guys, please.
Binary, sir. It's binary.
Yeah. Binary and nominal.
Yeah, good.
Yeah.
So next question. Yeah, some people are urging me to. Okay, male, female. Yeah, next one. One of the data collecting is the expected fetal weight in grams. So.
Continuously.
Yeah. So think about it. There's a trick in this one. Think about it for a minute. Yeah. I put that on purpose. One of the data you're collecting is whether the fetus is small for gestational age or not.
Sir, binary then, binary.
Binary. Yeah. So fetus 1, fetus 2, fetus 3, fetus 4. This one, SGA, yes. Next one, no, he's good. No, normal. Third, yes, SGA. Fourth, yes, SGA. So I would say like male or female. Okay. So it would be continuous variable. Yeah. This is just like what we did. So here in that question, we transformed the expected fetal weight in gram. We put a cutoff which is 2.5 kg. Any fetus below that will be SGA. Any fetus above that will be no SGA. So,
but this it is continuous, huh?
Yes. Okay. You know, your colleague are urging me to run. So yeah. Okay, Dr. Suman, thank you. I'm really sorry about that. Thank you. So regarding the relative risk, now we're talking about the measures of association. Okay. Could you please, guys, I will wait for, 10 seconds for you to please mute you guys. There's so much echoes around. Okay. Mute your mics, guys, please. Okay, this one, regarding relative risk. Yes, you can ask by, in the chat box, guys, please. Sorry, there's so much of you attending today, and thank you so much for listening. Thank you so much for bearing me. Okay, so regarding relative risk, which of the following statements is true? Okay, relative risk, I'll read about one by one because this is very important for you to understand. It's a measure of association used to interpret cohort study ratio of the risk of the unexposed compared to the exposed, or is it the risk, relative risk equals 1 means that there is definite exposure? Okay. Which one is true? B. So I just need you to look at this. Look at this one. Well, first of all, we will do it together today, okay? Because this is very important for you to understand, okay? So we will take this, we will take this table, sorry. We will take this table, okay, that this is our study. We will take those two categories, the weight category, the HPV status, okay? So the weight will be obeys, non-obeys, and HPV status will be positive and negative. We just need to count how many obeys with positive, how many obeys with negative virus status, and the non-obeys again do the same thing. We at the end of the day, we'll have something like this table. You need to just remember this study of the exam. You'll be fine. Okay. Here you put the exposed and the rows. You start from here. The first row, the exposed. We have, the obesity. We need to discover the relationship between obesity and HPV infection. You can, state that HPV is more common in obese patients. Okay. So the exposed. Obese patients, this is the exposure, obesity, okay? How many obese and positive, okay? And in the columns, you put the disease status, the outcome, the effect, okay? The end result, HPV positive, HPV negative. Okay, guys? Is that clear? Okay? So in the first cell, it'll be exposed and diseased. So we have obese and positive, three patients obese and positive at the same time. And you carry on like this, B, exposed and no disease. So this is cell number B. Obese, so they're exposed, but no, they're negative. No HPV infection. We have 4 cases like that. Total exposed are 7. And unexposed and infected 2, unexposed and not infected 1 woman, total 3. So we need to assess the risk ratio. What is the risk ratio? Risk ratio, the ratio between 2 risks. What is the risk? If I told you that if you have 100 lady of heavy menstrual bleeding, so, and we have among those women, we have 10 women with cancer. So what's the risk of cancer among women with heavy menstrual bleeding? What's the risk of cancer among women with heavy menstrual bleeding? We have 100 ladies of heavy menstrual bleeding. 10 of those ladies got cancer. So what's the risk of cancer in women with heavy menstrual bleeding? So tell me, guys, simple, 10%, 10 ladies, divided by 100. So same thing here, we divide You need to get the risk. So risk of getting HPV infection while obese is 3 divided by 7. So 3 divided by 7. And the risk of getting HPV while not exposed in thin women, in non-exposed women, in non-obese women, it's 2 divided by 3. 2 divided by 3. So this is will get you, so 2 by 3 equals 9. So this is the risk ratio. Okay, risk of exposed divided by risk of unexposed. So A divided by A plus B, which is this one. You know, those cells, you need to remember those cells. Yeah. So like this. A, B, C, exposure. Very important to remember it like this. Otherwise, you're not going to solve the questions. Okay, risk of exposed of the risk of unexposed. A divided by A plus B, all divided by C divided by C plus D. This is the risk ratio or relative risk, sometimes, or RR. Okay. Odds ratio, next thing, odds ratio. Odds ratio means ratio, again, it's a ratio between two odds. The odds means cell A and cell B divided to each other. If I have like 10 people, like 6 females and 4 males, so the odds will be 6 to 4. We call this the odds, 6 to 4. So divide 3 by 4, all divided by 2 by 1. This, so there's no totals in the odds ratio. Simply, it's AD, A multiplied by D divided by C multiplied by B. ADBC. AGBC. Okay, this is the odds ratio. So it's the ratio between the odds in the exposed group divided by the odds in unexposed group. Are you okay with this, guys? I think you had, you know, a little bit of experience in the odds ratio relative risk. Okay, good. Next. So the interpretation, yeah, it's the opacity. So in the previous example, we said 3 divided by 3 plus 4, which is this one. 3 divided by 3 plus 4, which is 7. So, and all divided by 2, 2 plus 1. So the risk ratio here would be 0.64. What do you understand from this? The risk ratio is 0.64. 0.64. You see what I mean in the matter. I know this slide might not be that clear, but this means that the obese women are at lower risk of having cervical cancer than the non-obese. It's less than 1. Yes, Dr. Mai, that's correct. Just bear with me for a slide and everything will be clear, I promise, okay? The risk ratio is reported. This is the next important thing, okay? The next important thing. The 95% confidence interval that it comes with the odds ratio and relative risk. It completes the relative risk and odds ratio. No odds ratio, no relative risk should be reported without its 95% confidence interval. I'll show you what I mean. Okay, first the interpretation. If relative risk is less than 1, like in the previous example, so exposed is at lower risk than the unexposed. Yeah, because they less than the unexposed, because the exposed in the numerator and the unexposed in the denominator. Yeah. So sorry again about the train. Sorry again, guys. Sorry. If both are the same, so exposed group is no less and no more than the risk. They're both the same thing. Okay, both are the same thing. If risk ratio, I mean, they work the same for the odds and risk ratio. Same thing. Okay, same thing. Risk ratio more than 1 exposed is at lower risk than the unexposed. I mean, sorry, this should be, I need to correct this. Sorry, guys, really. higher risk. Yeah, sorry about that. I'll correct that. Just clear, guys. So here, like for example, risk ratio 0.6, 0.6. Here, risk ratio equals 1. Like here, for the risk ratio equals 2.7. In that 2.7 times more risky than the unexposed group. Clear, guys. Very simple, is it? Odds ratio works the same thing. Okay. All right. What about the 95% confidence interval? What is this? Just please, for the sake of the exam, if you say 95% confidence interval, means here we are talking about the real world. We're not talking about your study. We're not talking about the people in your study. We're talking about if you repeat your study in the whole world, in the whole population. We say, please, every time, just bear with me, listen to me, please. Every time you see 95% confidence interval, strike it off in the exam and say that instead, we are 95% confident. We are 95% confident that the range in the real life is between this and that. Okay, is this clear, guys? Okay, so in our study, we said that the odds ratio of relativist is 0.64. But what about the real life? We didn't do a study for every woman in the world. Yeah, we didn't do that at all. But we just did like a sample, like a 100. What's about the real life? Because statistics is all about real world, not just your study. Yeah. So you say that we are 95% confident. You know, there's a whole bunch of equations. They're so complex and so complicated that are used to calculate the 95% confidence interval. But you say that you're 95% confident that the range is between this and that. This and what? First, if the 95%, for example, these are 3 examples. First, between 0.1 and 0.6, like this one. So they're all, you know, take care of this. All are below 1. Yeah. The whole range is below 1. It's from 0.1 to 0.6. Is that correct? So we are very sure, we are 95% confident. We are 95% confident that the range odds ratio or relative risk in the real life ranges between 0.1 and 0.6. At any ways, it could be 0.1, 0.2, 0.3, 0.5.5, 0.6. Is that correct? For at any case, it's less than 1. So there's a protective effect. The exposed group are at lower risk than the non-exposed group. Next example. Example. There's one. This time, see this. 95% confidence interval, 0.8 to 2.2. From here to there. Well, actually, I'm saying I don't like the word 95% confidence interval, but I would say instead that I'm, as a researcher, if I repeat the research again in the whole population, in the real world, yeah, I'll be 95% confidence that the range, yeah, lies between 0.8 and 2.2, which actually, listen to me, please, doesn't make any sense at all, because basically I'm saying, because could be less than 1 here, could be more than 1 here, or could be exactly 1. Basically, I'm telling you that the exposed group could be at less risk, could be at the same risk, could be at higher risk than the non-exposed group. This is what the 95% confidence interval tells you. Right, guys? Please tell me, does this make any sense to you at all? Did I tell you any new information? Did you get anything from my research? If I tell you that the exposed group could be less or as equal or more than? No, this is non-significant. Every time you see relative risk odds ratio crosses 1, 100% sure that this is non-significant result. It should be non-significant result. Basically, both groups are the same. Basically, the exposed group and non-exposed group are the same. The exposure doesn't have anything to do at all with the outcome. Yeah, because one is a probability here. One lies between one is in the range here. There's one here in the range. Very important because so many colleagues, they puffed about it. Yeah, non-significant Dr. Nada. Yeah, perfect. Perfect. So third example. There should be more than, guys. Sorry, and so much mistakes. But sorry about that. So last one. Yeah, the 95% confidence interval lies between 2.5 and 3.2. So the whole range is above 1. Yeah, whole range is above 1 here. Do you see 1 in between? No. So basically, I'm saying that we have 95% confident. Yeah, Dr. Javier, yeah. The wider confidence interval, the less accurate the result is. Okay. And we'll explain that in the meta-analysis, but later on, maybe not today, but I need to clear that concept. Every time you see odds ratio, relative risk, I'm talking about the 95% confidence interval. If it crosses 1, means non-significant, means p-value more than 5%. Simple thing, yeah? So, examples. Tell me about this one. Odds ratio 0.5, 95% confidence interval, 0.1 to 0.8. Significant or not? For the first example, significant. So I expect p-value to be less than 0.5. Next one. So next one. So next one, not significant. Touches 1, not significant. I expect p-value to be more than 0.05. And the last one, again, it's not significant because there's 1 in between. So p-value, again, 0.05. That's it. So we finished, we're done with the confidence interval. Are you happy, guys, till now? Good. So another set of questions. You're welcome, Dr. Hadil. Okay, another set of questions. So explain again 2.5, 3.5. So yeah, I know this is very important. This one, what are you talking about? This one, the whole range is above. Yeah, this is 1. So we all above 1. So we all, yeah. So we are 95% confident that the exposed group at higher risk, at more risk than the unexposed. And the range between 2.5 and 3.5. We're good unless we touch 1. Okay, guys. So question 13, if a series of values consists of 21 numbers, then for the finding of the median, we order the series ascending from the lowest value till the highest value. So now we need to talk about the median. What's the median in this? It's the observation number 11. Does anyone of you have, the middle? Median means the middle. Mean means the average. Okay, I do have something for you, okay? In a very nutshell, okay? Yeah, good. So all of us clear what the median means. Would you like me to explain this part? Or carry on? Okay, Dr. Zia, so, okay, question 14. Question 14. Okay, Dr. Ruben. Okay, question 14, correlation. Correlation coefficient computed for 2 parameters measured in 429 patients is R equals to 0.829. So what's this? What is this? So the R, the correlation coefficient, lies between this and that. So what does it mean? Oops. So, okay. The two parameters, that would be correct answer, that's correct, are directly correlated because it's a positive correlation. So the correlation, the R ranges between -1 all the way to +1. If it's 0, means no correlation. If it's -1, powerful or strong negative correlation. If it's +1, means strong positive correlation. Here we are 0.8, so we're somewhere here. So the two parameters are directly correlated and the link is strong. Yeah, so we're approaching one. And this is how you interpret. We have three main correlation coefficients: Pearson for the parametric data, Spearman rho for non-parametric data, and Kindle's tau for the ordinal data. Say link is weak, you know, it varies. Look at this diagram, doctor, okay? The more it approaches 0, we say it's weak, like this. If it is like 0.01, 0.009, like here, somewhere, or minus 0.01. That should be a weak correlation, weak negative or weak positive, depends on the positivity or negativity of the correlation. Okay, the more we, you know, get away from the 0, the more we get stronger. So the Pearson for the parametric, the Spearman for the non-parametric data, if the data are not normally distributed, and I'll show you what I mean in a minute. Yeah, and the Kindle's for the ordinal data. Yeah, approaching 0 is weak. Like this one, Dr. Ziad. Bear with me for a second, please. So, can you see this one? R is 0.9, yeah? This is a rate study, by the way, so it's almost 1. This is a perfect correlation, like this. The more we get to the right, the more strong the effect is, yeah? Well, take a look at, you know, another one, this one, for example. This is a strong negative because it's the other way around, yeah? So negative look like this, you know, getting down. Getting up means positive, getting down means negative, okay? Good. Do you know what 0 looks like? Okay, Dr. Zia, no pressure. I'm sorry. So 0 correlation will look like this. This is 0 correlation. The more we get to the right, nothing changes. Nothing changes on the effect. Like if you know, using a new antihypertensive medication group of patients, okay, you figure out in your study that the more you know, increase the dose of your medication, nothing changes the blood pressure. This means the ineffective one. Yeah? Do you get me, guys? Shall we continue?
Yes, sir.
Okay. Okay. Question 15. For a clinical trial, now we finally came to the world of sensitivity and specificity. This is a tricky question. Please. So guys, what do you think? For a clinical trial, the sensitivity is 0.56 or 56%. Specificity is 89%. We know that specificity is sensitivity, positive predictive value, negative predictive value. They all range between 0% all the way to 100%. Yeah. Odds ratio, relative risk from 0 to infinity. The correlation between -1 all the way to +1. Okay. There is nothing called negative odds ratio or negative risk ratio. Nothing called like this. Okay. So what do you think about this? Clinical trials, sensitivity just 56%, specificity is so perfect and high. So what do you think? Someone says, hey, the test is valuable because both indicators are more than 50%. So 50% sensitivity means that you have a lot of errors. Like half of your population, you misdiagnose population. B, the test is worthless since it gives errors when detecting both sick and healthy subjects. Why? We have 90% specificity, so we're very good at detecting healthy people. Specificity is all about the detecting the negative people. So we're very good at detecting healthy. Specificity is so high, guys. Remember that. We are very good at specificity. So it's a perfect test. Do you think it's a perfect test? Do you think, is this a perfect test? No, it's not. See, I know it is, sometimes, yeah, it's low sensitivity. Low sensitivity means, could you please tell me, just stop the chat box, could you please tell me low sensitivity, okay, means high false positive or high false negative?
High false negative, sir.
High false negative. Low sensitivity means high false negative. Perfect. High false negative. Is it type 1 or type 2 error? Back again to the null hypothesis. High false negative. Type 2, dangerous. Do you know what that means? Low sensitivity means that you're examining the lady, yeah, suppose that she got cancer, but you don't know, you're just doing the CT or MRI, a new CT modality for the patient, and you failed to diagnose that this lady got a cancer, and your report was negative. She's fine, and you send her back home, okay? That you killed the patient. You're very loss sensitive. You're very loss, and your device is very loss sensitive. You see what I mean, guys? This is a very bad test, by the way, the worthless. It's a very bad screening test. Another important table that you should remember in the exam, another 2x2 table as well, but this time we'll not be talking about the exposure and the effect. This is one of the analysis of some kind of study. We call it the DTA. Yeah, it's C, Dr. Ruba. Yeah, it's C. Sorry, guys. So, it doesn't show, but it's C. Yeah. This is the correct answer. Okay, there's one. This is a kind of a study that we call a diagnostic test accuracy. Like, for example, in our guideline, we study the sensitivity and false positive rate of combined first trimester test with the Down syndrome. Yeah. So we say that 90% sensitivity and 5% false positive rate. Is that correct, guys? As far as I remember. Yeah. So we compare. This is called a diagnostic test to accuracy study. So we start with the test. Right here would be the combined test. The combined first trimester test. The nucleotranslucency with the Papa A. Yeah. And here would be the truth. How did we actually confirm with the disease? Yes. By using the amniocentesis, some DNA, we get some DNA from the fetus, like amniocentesis or so, and then we see if that fetus really got Down syndrome or not. So again, box A, cell B, cell C, and cell D. But this time they'll be gonna exposure and disease and the other stuff of risk ratio and odds ratio. Please don't mix things together. And the previous example was about the exposure and disease, but this time we're talking about DTA, diagnostic test accuracy. So we're talking about less accurate test and the gold standard test. So we need to true positive, A, false positive, false negative, and true negative. Okay? Give me for a second. Table. Again. A, B, C, D. Okay? Forget about this. I don't like this in the DTAs. So do it like this. Do it like this, okay? True, positive, true, negative, okay? Then, so like a diagram. False, positive, false, negative, okay? So true, positive, true, negative, positive, false, negative. The positive, the top, negative, at the bottom, okay? Okay, good. So how to calculate sensitivity and specificity? So sensitivity means true positive divided by true positive plus false negative. So this is sensitivity, and this is specificity. This is positive predictive value, and this is negative value. In my drawing goes like this. So again, repetitions makes you remember. Again, base one. Again, true positive, true negative. Okay, false positive, false negative. Okay, oops, sorry. Start again. Okay, sensitivity, specificity, positive predictive, negative predictive. So sensitivity, specificity, positive predictive, negative predictive value. In your own handwriting to be much better. So again, so I'm sorry guys. So yeah, this one. So if you don't know the equations, it's going to be so useful and rapid for you in the exam. Yeah, to remember that. So sensitivity, true positive divided by the total of the column. True positive plus false negative. Okay. And specificity the other way around. We go from the bottom to the top. True negative divided by the total. Yeah, total negatives. Total negative plus false positive, the total column. Okay. Okay. False the positive predictive value and negative predictive value. Believe me, they're much more easier to remember than the sensitivity and specificity. I'll show you why in a minute. Positive predictive value. The whole equation is positive because it's positive predictive value. So everything is positive. Negative predictive value, everything in the equation is negative. So positive predictive value, true positive, divided by the whole positive, the true positive plus the false positive. The negative predictive value the other way around, all negative the equation. So true negative divided by true negatives plus false negative. Okay? Do you get what I mean? Again, the train. Okay. Shall we continue, guys? Are you clear with that? You know, please, although you all need to do is to draw this in your handwriting and repeat this over and over again. Remember that sensitivity goes like this, specificity, positive predictive, negative predictive. In all equations, the truths are the denominators. No false thing in the denominator. True positive here, true negative here, true positive here, true negative here. And the positive predictive value, negative predictive value, PPV, all positive. Negative predictive value, all negative. Yeah? Every denominator is true. Every numerator is true. Every numerator is true. So yeah, this is just like an example. I think you're now cut to that. So there was, yeah, this is slide I missed. So this is just a mnemonic. Like actually, I tend to sing like a song. Okay, we're always concerned about making mistakes. This is just a mnemonic in DTAs for you, diagnostic test accuracy. So please, the false result, and we care about sensitivity more to avoid false negative. So we care about sensitivity and we care about avoiding mistakes. Okay, so sensitivity related to false negative more, and specificity with a P related to false positive. So high sensitivity, low false negative, low sensitivity, high false negative. So when the sensitivity is high, false negative, so the N on the N, okay, go, opposite to each other. High sensitivity, low false negative, low sensitivity, high false negative. And for specificity, the other way around with the P. High specificity, low false positive. Low specificity, high false positive. How about that, guys? What do you think about this? So now, next time I'm going to ask you, what does it mean when I say that the test has low sensitivity? You say high false negative. Low sensitivity, high false negative. High sensitivity, low false negative. Okay, and specificity with the false positive. Okay, so question 16. Tell me. Sensitivity of a clinical trial. Okay, so your answers, guys, this is a question, by the way. Is it ratio of sick patients diagnosed as positive in the total number of sick patients? Okay, come on, guys. What's your answers? Nobody has answers me except Dr. Zia. Okay, Dr. Javira. Yeah, you saw the answer. Okay. Okay, sorry, I didn't realize that. Okay. So mute your mics, guys, please. Mute your mics, please. Somebody. Okay, so the sensitivity, sick patients diagnosed as positive, the total number of sick patients with the column, the first column on the left. Mnemonic. Question 16. Question
It is used to represent the average when the data are not symmetrical.
Guys, somebody, I don't know how to mute the mic on this application, so please, could you please mute your mic? Thank you. So what's used to present an average when the data are not symmetrical? I think we said that before.
I think median.
The median, yeah.
Yeah.
So here comes a very nice way to okay, guys, a very nice way to choose a test. I decided to put those slides finally in order to show you what I mean by choosing the statistical test. We heard about the t-test. No, it's not the mean, doctor. So when it's used to present the data when the data are not symmetrical. I'll show you what I mean in a minute. Just hang on, please. I need to. Please, guys, I don't know how to mute the mic for the colleagues. What used this application? Somebody, I think Dr. Hang on, guys. Dr. Vijaya. So, okay, now we do. Okay. Back to our lecture. Good. So, normally distributed variables. So think of this example. If I, in your class, in your medical school, if I collect 100 students, and I ask you, I just need to record their heights in centimeters, okay? Their height. In a normal distributed, in the perfect world, I should expect that most of my colleagues of those 100, you know, the range in the middle, the average heights, like between 160 centimeters to 170 centimeters. They all lie here around the mean. Yeah. Yeah. This is the mean 165 centimeters. Okay, most of my colleagues will lie in the middle. We have very few colleagues that they are short, like 100.4 meters, and we have very tall colleagues that they are like approaching 2 meters height. Well, most of my colleagues, most of the students lie in the middle. Yeah, most of our colleagues, most of our friends lie in the middle. This is a perfectly normal distributed, and it should look like this: a pill curve, inverted pill curve. Yeah, abnormal distributed, or sometimes called skewed curve. Skewed. Yeah, when you have more short people, or negative skewed, like we have more. Okay, we have more tall people in our sample. That will be abnormally distributed. And believe me, all you need to do today is to know whether the distribution is normal, is perfect, or not perfect. How can you, examine your distribution to say if it's normal or not? You don't. Statistical program will tell you, some complex equations will tell you whether your sample is normally distributed or not. Okay? It's not for you. There's so complex equations to do that for you. All you need to do is to interpret the result to say if distribution is normal or not normal, because it will help you to choose the test. What test? Like this, for example. Okay, again, please read that thing in yellow. This is for numerical variable only, like for weight, for height, for age, for number of metastases, parity. Those distributions are not for cancer stage, buzz, scoring system, binary, dichotomous. Those kind of variables have nothing to do at all with the distribution. Okay, every time you see a word continuous variable, like age, like weight, like expected fetal weight, like number of things, you think of distribution. If you don't see any kind of those variable, if your question in the exam with numbers and percentages, like male or female, like negative or positive, don't think of the distribution. This distribution is only for numerical variable. Okay, so description of the continuous variable. So in the previous question, if the data is normally distributed, we will use the mean, because the mean in that case will be the best representative of the central tendency. The mean means the average. This is what the mean is. Well, the median means the middle observation after resorting. If the data is normally distributed, okay, be with the median. Okay, so step by step, what is the distribution? Normal, mean, abnormal, median. Okay, and the mean comes the standard deviation. With the median comes the interquartile range. Good. Next question. You're so late today. What about the categorical variable? How do we, summarize the categorical variable? Do we use distribution? I told you no, not to think of the distribution, it's all the categorical variables. Categorical variable is super simple, super easy. Just number and percentages, right? Like what the number of SGA percentage in obese and non-obese mothers. What's the number and percentage of endometrial cancer in women with PB versus premenopausal bleeding? Number here, number there, percentage here, percentage there. That's it. That's all about the categorical variable. You don't need, there's not much fuss about the mean and median, nothing, because the no distribution for both guys, okay? And another hot slide for you today, guys. Today, how to choose the statistical test. Oh, there's typo here to be statistical test, okay? So we see things in green and we see things in brown, okay? You still with me, guys? You think I'm talking too fast? I actually got tired.
No, sir.
Are you bored? Are you bored? Good. Nothing to do, nothing would help you to memorize this silly looking table unless you repeat it over and over again, okay? It's silly, it's simple. Sometimes, I mean, I've been working the field of statistics. I'm a university member, so all the day I'm working with statistics, and sometimes I mix things. You need to repeat this. Questions will help you. Solving so much questions will help you to remember all these, you know, silly stuff. So what do you want to do? So first of all, focus on the green thing. Thank you, Dr. Nada. Focus on the green thing, okay? The numerical variable. Numerical variable. Okay. Guys, today, sorry, I have to use your mic. Thank you. Okay, sorted. All done. All done. Okay. So, numerical variable. What do you need to do? You compare two means, like the mean of weights in female students versus the mean of weights in male students. So we have two groups of people. I got like 100 male students in my colleagues, 100 female students in my colleagues. I need to compare the mean. I got the mean, like the mean weight of males like 100 kgs, mean weight of females like 60 kgs. Okay, I need to compare those together. First of all, those are what? Those are continuous variable, aren't they? So I need to do distribution. Are they normal distributed or non-normal distributed? Okay. So if they're normal distributed, I'll use something called the parametric test. Those are called the parametric test. Parametric, I forgot to. Parametric test. And thus I'll add that later. I'm sorry about that. I forgot to, mention the word parametric. Remember that for the description, we use the mean here. We use the mean and standard deviation for the normal distributed. Now I need to compare. I need to do some analysis, okay? So since they're normal distributed, I'll use the t-test. The t-test, okay? There's so many types of t-tests, but just for the purposes of this moment now, t-test to compare between two means. Are you clear with me? Okay, you get step by step. Suppose, okay, t-test. So t-test compare between the mean weight of males and mean weight of females. Perfect. Okay, now bad luck. Bad luck. Two groups are asymmetrical. We have so many like lightweight females and so many, heavy-weighted males. So the distributions are not normal, skewed. I can't use the parametric test here. I need to use some other test to compare between the two groups. Those are the non-parametric tests. Okay, non-parametric test, yes. Like the Mann-Whitney U test, sometimes called Wilkinson rank sum. Yeah, I know, silly names, complex names, but you know, there's so many scientists in statistics, and all the tests in statistics are named out eponyms, named after somebody. Okay, Wilkinson rank sum, same as Mann-Whitney test. Another non-parametric test is called Wilcoxon signed rank. Wilcoxon signed rank. So, not to be, you know, stay with me. Where are we now? We have two groups of people. We need to compare between the mean of one group to the mean of other group. If they are perfect, t-test. If they're not perfect, we use the Mann-Whitney test or Wilcoxon signed rank test. Okay, step by step. Suppose that this time, no, I have so many groups. I have so many groups. I have like this class, the previous class, the previous class. I need to compare the mean weight of female in this class, the previous class, the one that previous to the previous class. So how many groups we have? We have 3. Each one of those groups has a mean. So we have a mean weight of female in this class. We have a mean weight of females in the previous class, and again the previous class. Okay, can we use the t-test here? Can I use the t-test here to compare between the 3? No, ANOVA. There is one. So means of more than 2 numerical variables, ANOVA. Okay, ANOVA test. More than 2 groups, ANOVA test. Okay, if just one condition, guys, in one condition, if they're normally distributed, if the 3 groups are normally distributed, okay, suppose they're not. One of the groups are not normally distributed. More than 2, yes, Dr. Nusha. More than 2 groups, ANOVA test. Okay, suppose that the 3 groups are, you know, bizarre, they're not normally distributed. What should I do? You know, they like, you know, brothers and sisters. We have the main test, and we have its equivalent, its sister non-parametric test. We have the main parametric test, and we have its sister non-parametric test. Yeah, like t-test, that's the main test. The sister of the t-test, the non-parametric sister of the t-test, the Mann-Whitney test, and Wilcoxon signed rank test. The ANOVA parametric test does have a sister. The sister of the ANOVA test is the Kruskal-Wallis test. Kruskal-Wallis test. You know, it doesn't come a lot in the exam. You know, most of the time, this one, still question information about normality. No, I don't think. Just I need to finish this table first. I'm going to take your questions, okay? Okay, so you still with me, guys, or you got tired? Okay, we'll continue a little bit more. Okay, so we compare now the means of the 2. So we're done with the 2 numerical variables. We're done with the more than 2 numerical variables. So we're good with that. Suppose that we need to find the correlation this time. We're still in the numerical variable, still in the green zone, okay? We need to find the correlation between 2 numerical variables. Like what? Listen to me. We need to find the correlation between the dose of medication, like antihypertensive medication, and the blood pressure. Path continuous. Blood pressure, I mean real blood pressure, like systolic blood pressure. So the more I give the dose, you know, the blood pressure will get, you know, lower and lower. Yeah, is that correct? It will be negative, perfect negative correlation. So the dose of medication is numerical continuous. The blood pressure is numerical continuous. Suppose that both of them are normally distributed. So the dose of medication, normally distributed. The blood pressure is normally distributed. What kind of correlation should I use here? Pearson test, Pearson correlation coefficient. Pearson. Pearson is a parametric test, yeah? Every parametric test has its sister non-parametric test. Yeah? Who are the sisters of Pearson? Spearman for non-parametric and Kindle for ordinal data. What do I mean by the Kindle for ordinal data? Like, suppose that you need to find correlation between a dose of or combination of new chemotherapy agents and the stage of the disease. The more you give the medication, the more the stage will be less. Is that correct? It goes from stage 4, stage 3, stage 2, stage 1, acute. Yeah? So comparing continuous variable with the ordinal data. Since we have an ordinal data, we can't use the Pearson. We use the Kindle. Okay, guys. So for the numerical variable, you need to look at the distribution first. Normally, use the parametric. Not normal distributed, use the non-parametric. Every parametric test has its sister non-parametric test. T-test, Mann-Whitney, Wilkinson, and Sandline. ANOVA, Cross-Sectional, Pearson, Spearman. Cool? Is that cool, guys? Okay, perfect. Thank you so much. So now, what's about the categorical variables, which is the most commonly used, variables in medical researchers? Like, what do you want to do? So, number percentage of the disease and no disease. Just have one test. Do you remember that table of the obese, non-obese, HPV positive, HPV negative? If you need to compare those tests together to show if there's, that's okay to say. Yeah, I think we'll repeat that again later on, but thank you so much for your words. Thank you so much. It really, it really matters to me. Okay, so the number percentage, like back to the table of the obesity and HPV infection. If you could remember that, we have obese women, non-obese women. We have HPV infection, no HPV infection. Okay, can get the number, a percentage of each cell. I'll show you what I mean in a second. I think I'll be better if I know. Oh, no. Sorry. Okay, where is the screen? Yeah, screen. Thank you. Good. Square test. Very important for you. Hello, guys. Sorry, can you hear me? I'm sorry, I lost connection. Yeah, yes, I know that. I lost connection. I'm really sorry. Okay, so we're back. We're good as back. Good, good, good. So, okay, I'll explain the first class square because it's very important for you to understand. You're not going to calculate it yourself. How many cells can you see now? Tell me, how many cells could you see? So we have obesity, start with exposure and outcome the infection. How many cells? 4 cells. If I have 100 lady, total sample size, so the grand total would be 100. You know class square test? You know class square test. Sometimes written like this. This is the simplest and the most simple test in the whole world. I'll tell you why. I'll show what I mean in a second. The simplest, because if I have 100 lady and I have 4 squares, so I expect my theory, my null hypothesis, that each cell should be there 25 women. Okay, 25 women. I have 25 obese and infected. I have 25 obese and not infected. I have 25 lean and infected, 25 lean and not infected. Simple. This is the null hypothesis. But in my research, I didn't find like that. Yeah, I found like here 30, here 20, here like 40, and here's 10. So they're different. The observed are different than expected. How different? Are they significantly different or not significantly different? The chi-square test will bring me at the end the p-value. The p-value will tell me if that my observation is very different than the null observation or not, than the 25, 25, 25, 25, or not. Okay, so the chi-square, the purpose of chi-square is to test the observation, sorry, I just need to, okay, test the observation in the categorical variable of the sim, and you know, can be used in any kind of cells, 4 by 4, 5 by 5, 5 by 4, 5 by 3, any kind of observation, any kind, any number of cells, 4 cells, 5 cells, any kind, doesn't matter. Okay? Fresh exact test, same as chi-square test, same thing, but the different methods, same thing. Okay? So first you found association. So the p-value of the chi-square tells you no, those groups are not similar, are different, they're not similar. There might be, you know, some association. Next thing, I need to measure the association using the odds ratio relative risk. So first, if there is an association or no. Next, I need to quantify to get a number of that association using relative risk and odds ratio. Okay, this is how it works. So at the end of the day, this is all you need to, I just, first don't take screenshots of that because I just need to write here, this is the parametric, this is the non-parametric, not normal distributed data. One important thing that actually I thought it doesn't come in the exam, but it really does come in the exam. Okay, are you good till here? Are we good till here? You stay with me. Do you have any problem at all with this table? Is it simple? Good, good, good. Thank you so much. Thank you. T-test, because it does come in the exam like this. Okay, very important for you to know the difference between this and that. Okay, I have women, men. Okay, and this is the weight in kg, weight like 70, 60, 75, 80, 85, 70, 60. For men like this. So blah, 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 to the end. I got here the mean and the mean. So I'll be comparing the mean to the mean using either the t-test or the Mann-Whitney test if they're distributed, not distributed. That's one condition. The next one is very important. Women, same at that group. 70, 60, 70. And those women were given medication for weight loss. After a few months, I repeated the same measurement for the same women, for the same group. So they're the same people. And the new weight for the same women, for the same 5 women, is less. 60, 45, 45. Yeah, Dr. Soma, this is called the paired t-test or dependent t-test. The first kind, we call it independent t-test because they're not related to each other. The independent set of observations. But if I repeat the measurement for the same individuals, so I got 2 observations for one person, 2 observations for one person. This is called paired. So because each lady, like there'll be a case number 1, be weight 1, weight 2, weight 1 70, weight 2 75. So they're paired. The paired observation called paired t-test. Back to our table. That's what I'm talking about. So t-test could be independent. So blood pressure level and fasting, and 2. Yeah, this is called paired t-test. Okay, paired t-test. Okay, every time I have 2 observations for the same individual, that's called paired t-test. So if there are 2 groups independent to each other, we call the independent t-test. If they are paired samples, okay, we call the paired sample t-test. Distribution, good, Dr. Jane. If they're normally distributed, we use the paired sample t-test. If they are not normally distributed, look at that. If they are independent group, we use the Mann-Whitney or the Wilkinson rank sum. If they are paired sample and not normally distributed, yes, I'm talking about this. Yeah, focus. Bear with me for a second. We call the Wilkinson signed rank. So the signed rank is for paired abnormal distributed. Mann-Whitney test is for paired, independent, but abnormally distributed. Okay, so again, guys, this is very important for you. We have normal distributed, abnormal distributed. Yes, Dr. Xavier, distributed. Normally distributed, abnormally distributed. We have independent samples, we have paired samples, 2 observations from one person. Independent and normal distributed, just independent t-test or t-test. Paired and normal distributed, that will be the paired sample t-test. Paired sample t-test. So, okay, t-test is the independent t-test. Okay. So for the independent t-test, it is normal. So I told you in a minute, I told you a couple of minutes ago that every statistical test, parametric, has a system. Yeah. So the system of the independent t-test is the Mann-Whitney. The system of the paired t-test, signed rank. So are you happy till this moment, guys? This is very important for you. You know, a lot of colleagues, baffle about that. Hello, guys. Tell me, are you clear with this point? Good. Okay, shall we continue? Okay. Student t-test is basically the same as just t-test. Student by the name of, Mr. Pearson. Use his name like a student. That's his pen name. A pen name, the name that you use when you sign your books or so. That's the pen name of Pearson. Yeah, that's correct, Lucia. That's correct. The other name of the independent t-test. Okay, so this table, I told you, me myself, I tend to forget some important point in it. The only way to not to forget anything is to repeat that again and again and again. Remember that every parametric test has a system. So study that in pairs. Independent t-test, man with me. Paired Samba t-test, Wilkinson signed rank. ANOVA, Cross-Sectional Study. Pearson, Sperman. That's it. I'll make it like a song. Next question. Question 17. We have like 5 questions to go. When they mention studying the time section taken to pre-exams here. This is another whole of the study, Dr. Suma. I'll explain that. Can you please repeat your question again about the Caesarean section of pre-exams at the end of the lecture? I'll be happy to listen to you. Would that be okay with you? Okay. So, question 17. An oncologist suspects that many women diagnosed of having breast cancer, also have high levels of work-related stress. We will spend like 30 minutes from now discussing the different study designs, okay? What type of design would be the best to test the possible association? Again, an oncologist suspects that many women diagnosed as having breast cancer, maybe due to high level of work-related stress. So, would be the best test to study this possible association? D, perfect. That's the correct answer. If you're not familiar with the study designs, I need to explain many things. So this is what you need to remember at the end of the day. We have 2 main study designs. We have observational, we have experimental. Observe, we don't interfere. We don't intervene. We don't, do anything with the patient. We just stand there and observe, okay? Like you're in the zoo or something. And experimental is where you intervene, where you interfere with the patient. I'll show what I mean in a second, okay? So how many observations do we have? We have more commonly prospective cohort study. We have case control study. We have cross-sectional studies. Okay, the common experimental studies, the RCTs and quasi-experimental. So we have less common, I'll explain that in the end. We have case series and comparative. And we have something called matched case controls. We have something called nested case controls. Yeah, so don't freak out, please. I'll explain all of that. And we have also something called retrospective cohort study. Yes, perfect, Dr. Ziad. Perfect. The whole, thing in medical statistics or biostatistics or statistics in medicine, we study 2 things. Yes, Dr. Ziad, you're correct, Dr. Ziad. You study with the exposure as relation to the effect. Sometimes it's called cause and effect, exposure outcome, risk factors, and the disease, or you name it yourself. It has different names, but this is the relationship that all research, all statistical tests are focused around, exposure and effect. Okay, through observation, through experimental. So we can study this relationship through observing the patients or through doing some experiments? First one. Now I need you to tell me. We start with this. I grouped some exposed women, like obese women and non-obese women. Okay, and I will end over time, study over time, till I give the effect. Some exposed women will give the effect. Some exposed will be no effect. Some unexposed will have the effect. Some exposed will be no effect. Is it clear for you guys? What kind of study is this? What kind of, I need you to tell me, what kind of study is this? Cohorts. Do you have any problem with this? Simple, isn't it? Yeah? Simple. Prospect. No. Dr. Rubaba. Was it clear for you or not? You said not. Okay, no problem. Okay, so my bad. Don't worry. So this is a prospective cohort comparative study. Good. Next one. So, and you know, at the end of the day, you'll see how many exposed, effect, exposed, no effect, unexposed, effect, unexposed, no effect. You get the table. Sorry again, the train. You get the table again, like your pays, no pays. So you get here in the prospective studies, prospective cohort study, the main measure of association will be the relative risk. Don't ever forget this. Relative risk, basically, this is the main. You can, yes, you can do the odds ratio, but that will not be perfectly accurate. I'll explain to Tanusha the retrospective cohort in a minute. You know, I have a whole slide for this, but for the purpose of this is very important because it does come a lot in the exam. Okay, what is the main measure of association in prospective cohort studies? It's the risk ratio, relative risk. Because we start with the exposed and non-exposed, so this will be our concern. Okay? Mute your mics, guys, please. We're not going to use the odds ratio in prospective cohort study. Yes, you can use it. Theoretically, in mathematical terms, you can use it. You have all things in front of your eyes. You can do the A, G, B, C. Yeah, that's okay. But clinically, this will not be very accurate. I'll repeat that again one last time. Prospective cohort study used the risk ratio to measure the association between the exposure and the outcome. Guys, please mute your mics. I'm very tired to tell you. Thank you. Next. Just hang on a minute, please. Whose mics is open? Whose mics is open, guys? Nobody. Good. This time, I'll start with the effect and no effect. Like I went to the hospital archive. I got 100 case notes and started the effect and no effect. Like I got 100 case notes of women with breast cancer, 100 case notes with just random women, like women with nothing at all. I'll go back in time. Sorry. Go back in time. To see how many women with breast cancer like had used at some point in the past HRT. That'll be written in the case notes. Sometimes you phone the patient. Sometimes you go to the other hospital to get other notes. Sometimes you call the GP. No, this is not retrospective cohort to zero. No. You start with the effect. You start with the disease versus no disease. And then you go back in time. Sometimes you phone the patient. You make, yes, this is a classic case control. Some people with breast cancer may have used HRT at some point. Some other they hadn't. Yeah. But also, some women with completely normal without breast cancer, the other group, you know, sometimes they had used HRT. Yeah. Some others they hadn't. Yeah. Don't worry. That's okay. We all get confused. Okay. So this time, this is called retrospective. This is retrospective because you go back in time. Yeah. What did we start this time? Retrospective code. Yeah, I have a full slide on that. Just bear with me for a second, please. I'll explain what I mean with the retrospective code because it does, it shows in the exam, shows in the responses of the MQs. Yeah. So if we start with the exposed and unexposed and go prospectively with the time to end with the effect, no effect, this is called a prospective code. If we start with the disease, like breast cancer, no breast cancer, and go back in time through the case notes, through phoning the patient, through contacting the GP to see if they're exposed or not exposed, if they had used HRT or no HRT at all at some point in time in the pack. This is called retrospective. We call guys, this is case control. Case and control. What do you mean by case? Case means disease. A case patient. This case, a patient, breast cancer patient. Control, no breast cancer. So we go back in time to see if they exposed or not exposed. Is this clear? Is this clear, guys? In the retrospective design, it's better for you to measure the odds ratio. This time we do the odds ratio. Odds ratio. Okay, not the relative risk. Relative risk doesn't mean anything at all, doesn't make any sense. Odds ratio. Okay, in the retrospective design, we use the odds ratio. The prospective design, we use the relative risk. Yes, we can do both. I told you, because we have, at the end of the day, we give the table. We give the table with the 4 cells, as we know, the A, B, C, D. We can do everything. But I mean, clinically, retrospective odds, prospective risk ratio. Okay? Just there's a whole, some, explanation of that. But I'll confuse you, believe me. So it's better for you to memorize it like this for the moment. And at some point later on, I'm happy to explain it. It's very simple, but today I'll confuse you by explaining why we use the risk ratio in the prospective, odds ratio, retrospective. Some other, subtypes of the retrospective case control. I told you case control, okay? Case control, cases and controls. Don't ever forget this. Cases and controls. Disease and no disease. Then we'll go back in time to see if they're exposed or not exposed, okay? So there's some other case control called matched case control. I think you saw that a lot in the exam, matched case control. What do you mean by matched case control? So in matched case, like we have 100 women, breast cancer, 100 women, no breast cancer. But I'll match those to those. Like I'll make the age similar to the cases. I'll pick the weight. I'll pick the gender. Yeah, of course. I'll select women with the same ethnicity. So I'm controlling other factors. I need to suppose that I need to examine only the effect of HRT. So many trains today. Don't ever think to live near a railway station again. Yeah, that's a blunder. Yeah, that's my bad, my mistake. Okay, so 100 cases of no breast cancer matches to 100 cases of breast cancer. Okay, same level, same age, same weight, same gender, same ethnicity level. So I'm adjusting for the other factors. Okay, I need to explain. Yeah, because someone of colleagues might tell me, okay, you proved that the breast cancer is related to HRT because so many women using HRT developed breast cancer later on. And I think you're biased. There's something wrong in your research. Maybe your cases were all obese. Maybe, thank you, Dr. Ruba. So maybe your cases were all obese. Maybe your cases were all diabetic. Maybe your cases were all old age. So it's not the HRT. Maybe other thing, intervened with the process of exposure and, disease at the end. Okay, you're correct. Next time you will control for the other factors will be equal. So nobody would say that age made a difference because they're the same age, or weight made a difference, or gender made a difference, or ethnicity made a difference. No, the same gender, same everything, same mean of age, same mean of weight, same gender, same ethnicity. Okay, so this is called by matching case control. Very important because it turned up in the exam. It turns up in the exam. Okay, nested case control. Could you please forget about this for a second, because I have a whole slide. This is very complex, nested case control. But unfortunately, I've seen this word many times in the responses in the MQs in the exam. Okay, so I'll explain that in a minute, but not now. Okay, just in 5 minutes. But do remember that we studied matched case control, and we need to know about the nested case control. Okay, we have 3 case controls now: the regular one, nested, and matched. I told you about the the odds ratio for the retrospective studies. What is this? We study exposed, unexposed, and no time. Do you see any time? No time between the exposed and non-exposed. No time at all. Yeah. We need to see if there is effect and no effect. If there is disease and no disease. What kind of study that is? What kind of study that is? At the same time, no time. We don't study the effective time over the exposure. Yeah, say that we have one lady of postmenopausal bleeding. You sit in the clinic over a week or so, okay? You collected like 1,000 patients over a period of 2 years. Every lady, you had a papil sample to examine if she had cancer, hyperplasia. This is not longitudinal observational, no. This is cross-sectional study. This is a classic cross-sectional study. Cross-sectional study. If there's no effective time, you do the cross-sectional study. Your mice, guys, please. Thank you. Okay, I'll explain that. So, well, first of all, cross-sectional studies, yeah, that's good, Dr. Malika. Not suitable to measure the association. We can't do the odds ratio. Again, mathematically, yes, you can. Clinically, not relevant. So should it be used to calculate the risk ratio and odds ratio? It's better to be calculated through retrospective or prospective cohort study or case control study. They're perfect in finding the prevalence, like mass surveillance of the people. You examined all cases with postmenopausal bleeding. This is an exposure. We need to find the prevalence of endometrial cancer among women with postmenopausal bleeding, which is 10 to 15%, by the way. How did they discover that? They had like 1 million women with postmenopausal bleeding, and they examined the rate of cancer within those population. It turned out to be 10 to 15%. Okay, and also you can do prevalence in non-exposed population. Okay, and compare two prevalence to each other. I'll show you the instance in a minute, Dr. Zia. I have a slide for that for you. Actually, it's a case series study. So it raises the hypothesis, but does not test the hypothesis. You can't use any comparison. Okay, it can suggest that maybe some association, but it can't measure the association. So all you need to do about the cross-section studies is to remember that they used perfect for prevalence, or compared to prevalence to each other. Okay, good. I have a question for you here. Okay, suppose that we have 1,000 lady with postmenopausal bleeding. You obtained endometrial papillary biopsy. The number of women with endometrial cancer, this should be cancer, was 100. What's the study for that? Simple. We just did that in a minute. Cross-sectional. Is that correct? Cross-section. So the next one is tricky. The next one is tricky. And I saw that question in some books, by the way. similar question. After 10 years, you did that study, you're happy with that, you published the study. After 10 years, the new gene was discovered for endometrial cancer. You return back to the 1,000 endometrial sample. Suppose that you saved those samples in a container or in your archives or so in a special container. So you get back to your 1,000 samples. You drew them back and you studied that gene expression after 10 years, but on the same sample. So what kind of study that is? I told you, it's tricky. No. Why case control? Why case control? No, it's not case control. No. Yeah, Dr. Sanaya. Yeah, still cross-sectional study. Still cross-sectional study. Okay, I fooled you with that 10 years. And this is very important. It doesn't mean that you have time. That will be observational study. Suppose that instead of that's 10 years, few days later, you examine that new gene on those 10, no follow-up, perfect. We didn't study effective time of the samples. Suppose that, no, not 10 years. Suppose that I drew those 1,000 samples and I studied the effective gene immediately. Single point of time. Yeah, please guys, listen to me. Those 1,000 samples are just 10 years old. Still the same point of time. I didn't draw another samples. Point of time. Like this. Okay. So, okay. Sorry, I have to repeat this because, now it's important. Time. And here, like year 2010. Okay, year 2010. 1,000 samples. Okay, and save. So they are freezed in time. I studied rate endometrial cancer here. Okay, at some point later in 2020, new gene discovered. So get back to the point, guys. I'll get to the same 10,000, same cross-sectional. So basically, yes, I'm studying the new gene. Yes, I'm in year 2020. But in terms of the samples I have, I'm studying 10 years back. Same point of time. You need to ask yourself a question, please, because I actually tend to, mix things together. Okay. I'm no better than you, by the way. Some people much better than me in that. But you need to ask yourself a question. Did we study the effective time of exposure or not? If yes, it'll be retrospective or cohort study. As I showed you in the time. Do you see this? No, you don't see this. If you don't see time, yeah, I also explained to the retrospective cohort. Yeah, and I know everyone wants the retrospective cohort. Yeah. Okay, bear with me, guys. I swear I'll not leave you today until you finish with the retrospective cohort study. Okay. One more time, one more thing. I saved, the difficult parts till the end because I want you to clear your concepts about the most important things that, come in the exam a lot. Okay. So the final answer would be, okay, so cross-sectional study. Still cross-sectional study. Okay, I'll take questions later on at the end of the day. Okay, so randomized clinical trials. Sometimes you hear that words, randomization, allocation, concealment. Yes, Dr. Miller, perfect. Randomization, allocation, concealment. Sometimes we tend to, see that in the questions. Single blinded, double blinded, triple blinded. What does that mean? Randomization, the patient are randomly allocated. It's not you who decide which patient will take that. Remember, we're talking about the RCTs, okay? We're talking about the RCTs. We finished with the retrospective, prospective, cross-sectional, all other things. We're in a whole different level now, okay? We're talking about the highest, the gold standard, the best of the best studies. Yeah, we're talking about the best of the best, the top perfect studies in the medical field, RCTs, randomized controlled trials, or randomized clinical trials. So randomization, the patient are not randomly allocated. So we have group A, group B. Group A will take drug A, group B will take drug B. It's not for you who decide which patient will go here or there. Randomization, like tossing a coin, okay? Heads will go this way, tails will go the other way, okay? So randomly. Allocation concealment, the patient will receive a closed envelope, which will tell them which group they are allocated to. This will happen blinding. What is blinding? We have single blinded, double blinded, and triple blinded. Single means the patient doesn't know the treatment. So the treatment is white in color. They all, in box in the same box, for example. No inscriptions, nothing at all. They don't know whether it's a real drug or placebo, for example. So this is the first one, single blinded. So the patient doesn't know about the treatment being given. Double blinded, neither the patients nor the researchers do know. So if I'm the investigators, if I'm the one who assessing the patients for blood pressure or so, I don't know whether they take it, whether they took this one or that one. Triple blinded. Sometimes you have some people who assist you in the research, like a trainee or some other junior doctors who are, will give the patient the medication themselves. They don't do anything, or a nurse, a research nurse, for example. Triple blind means the three of you, the patients, the administrator of the treatment, and the patients themselves. Nobody knows anything at all. We're all blinded, triple blinded. Is that clear, guys? So single blinded, this is important. The patient doesn't know. The patient, not the doctor. Okay? The patient, not the doctor, because sometimes single blind comes like this. Single blinded means the doctor doesn't know. No, this is incorrect. The patient, just the patient doesn't know. Double blinded, you and the patient. Triple blinded, you, the patient, and your assistants, the administrator of the treatment. Simple. Cohort, RCT, and something called quasi-experimental. Bear with me for a second. What is the difference between cohort study and RCT? They are both prospective. Okay. So both start with exposure and end with the effect. Is that correct? Cohort study is observational. What do you mean? You're not intervening. You're not intervening. You're just observing what the patient is already taking or not taking. Like women taking COCs and POPs. I will recruit 100 lady taking COCs and another 100 lady taking POPs. Then I will follow up the patient over time to see how many breast cancer patients here and there over 5 years or so. Please answer me, did I tell which patient should take COCs and which patient should take POPs? Did I tell you? Yes, you sir, you lady, my lady, you take POPs, you the other one, you take COCs. No, I didn't do that at all. Did I? No, I didn't. On the other side, RCTs. This is very important because so many researchers, they don't know the quiet difference between both of them. Again, the perspective starts with the exposure, end with the effect. And this is experimental study. I do experiment, I do intervene. It's you who control which patients take this or that or not taking this or that. I will tell you, yes, you lady, randomly, you'll take POPs, and you, the other lady, will take COCs, and you POPs randomly. Or toss a coin, or sometimes the randomization will be done through computer-generated sequence of numbers. Okay, you lady, you'll take this one. You lady, you take the other one. This one, that one, this one, that one. It's you who decide which patient will take this or that. Are you observing? No, you're not observing. You do experiment. You do an experiment because you intervened. Is this quite clear, guys? Is this clear, guys? Oh, okay. Good. Fine, good. Okay, what on earth is the quasi-experimental? Perfect sample. It's an RCT, but without the R in the end, at the beginning. It's not randomized. It's a perspective. Start with exposure, end with effect. Experiment, because it's you who decide which one to take. Take this one or that, take this one or that one. But it's not randomized. I'll tell you what, okay, I'll work in the hospital on Saturday and in Monday and Tuesday. Okay. People on the Monday, okay, I will put them in the group A. People on Tuesday, I'll put them in the group B. This is not randomization. This is not randomization. Or I, see the patient and know what will be taken. She'll take this one, and the patient will know about that. Not blinded, no randomization. Okay. Yes, you do experiment. Yes, you do intervene. Yes, you tell the patient you take this one or that one, but without randomization. You see the patient, you like the patient, okay, so you'll take this drug. The next patient, you don't like the patient, so for example, you will allocate the patient to the other, bad treatment or so. You see what I mean? Do you know what I mean? Basically, so quasi, the word quasi means partially or partly or, half. Okay, so an RCT, but without randomization. Just a clinical trial. Good. Case series. Now we come to the word of incidence, Dr. Zia. Case series. It's this exposed. Then some people at the end will have effects or no effect. Do you have any? So tell me, can you see any comparative group here? Where is the unexposed? No unexposed. You start a single group and end with effect, no effect, no comparison. Very good. And study over time, but study over time. Yeah, okay. This is actually very commonly used in medicine. I'll tell you why. So they don't test the hypothesis. The perfect identification of the incidence. Okay. You can explore the exposure and the effect. At the end of the day, diagnostic case control. I'll explain what that means in a minute. So it's just serious disease, and usually new disease will less patient. Basically, to do such a study, like this, like suppose that you need to know the incidence of breast cancer. For example, how many women should you recruit for such population? Like you need to figure out the lifetime risk of breast cancer or endometrial cancer. How many patients do you need? Tell me, just make a good guess. Well, actually, it's much higher than that. You need thousands of patients, like 100,000 patients, to test the incidence of disease. If you read any case series, most of them will be about oncology or disease incidence. It will be in thousands of patients, okay? And over like long time. Cohort, Dr. Anusha, it must have a comparative study. It must have unexposed group. I explained, Dr. Ruba, just in a minute. I'll take it step by step. I know what I'm doing. I take it step by step. Otherwise, you'll be confused and I'll be confused. Do you understand now the case series study? They're very simple. You take like 1 million patients, 1 million women, you study them, you follow them over like 15 years. At the end of 15 years, you will know the incidence of breast cancer. Like suppose like 1,000 women develop breast cancer. So the incidence of breast cancer over the next 15 years will be 1%. Actually, it should be 12% for breast cancer. Okay, now you discovered the incidence of breast cancer using a case series study. Okay, clear. Nested case controls. I saved that till the end because it depends on the case series study. Please, till this point, does anyone of you, lost the way? Is anyone lost till this point? You just need to make sure that, all of you are, focused and still, yeah, I will explain the nested. Yeah, just in a minute. Doctor, bear with me. So, exposed, what's this? This is, you did the original case series study, yeah? Within that case series study, at the end of the day, thank you so much. So at the end of 15 years, you discovered that you have, so this is like 100,000 women, and this 1,000 women with breast cancer, and 9,000 women, they know breast cancer. In the case series study, you can't, comparative group, you can't, you need to find the association. Why those women, developed cancer. In the original study design, you can't know. It's impossible to know because there's no comparative group. How should you know? The only thing you need to do is to take a sample from no breast cancer women and sample from the diseased women and do a retrospective case control study. Okay, you review the notes, and if you're interested, for example, about HRT, see how many of those women had HRT, no HRT. So this is the hallmark of nested case control. It's a case control study. Start with the disease and no disease. Start with the cancer, no cancer. But the sample, you collected the sample from the original case series study. Bear with me for a second. I have a better slide for you. Okay, so you get back in time. So again, I'll repeat this again. You don't have to know too much details, but at least in the exam, if you see the word nested case control, you know exactly what they're talking about, okay? So which is better for you. So this is the original case series. Happy? You need to know why some people, some group undergo two studies. So this is the first study, the original case series study. So some women got cancer, some women didn't get cancer. You need to get back in time to see why there is like an exposure of interest, HRT they were using or not. So you get back in time after the end to do a nested case control. I have a better slide for you. Just bear with me. This one. You can take a screenshot of this one, okay? And this is, by the way, this is a real case series study, nested case control that was done in 1995, okay? So original case series study was 10,000 women, 10,000 women. Followed up like for 15 to 20 years. At the end, we have 1,000 breast cancer patients, 9,000 no breast cancer patients. You take a sample from the, like we take all the cases and just 1,000 of the breast cancer patients, of no breast cancer patients. You get back in time, we review the notes, we ask the GPs, we ask the families, we found the patients, we review their other records in other hospitals. Did this patient use HRT at some point or not? Then you can find the relationship. it's a case control, but it's nested within the original series within the case series system. If that's clear, guys, do you understand now? In the original case control, you don't have to follow this rule. You can get just any 1,000 patient from any hospital and 1,000 patient from any other hospital. They don't have to be in the original series. Oh, Dr. Ziab, so tell me, why are you lost? I still have some power for you. Tell me, what is not clear? Yes, you'll have a sample for that. And also, it'll be a recording that'll be uploaded. Okay, Dr. Ziab, no, are you okay, really? Did I, make you confused? Did I upset you by any means? Okay, thank you so much. So we're done with the matched case control, the original case control. We're done with the matched case control. Yes, but at the end of the study, you get back, okay? And we have also the nested case control. So matched case control, nested case control, and the original case control. So now come the hot slide for you that all of you were talking about. What is the retrospective cohort and how do we compare the prospective cohort study with the retrospective cohort study with the case control study? Here, please don't get crazy. Everyone will get crazy in this slide, okay? Don't wig out, okay? Your hair is not responsible for this confusion, okay? So don't pull out your hair, okay? No wigging out, okay? So prospective versus retrospective versus case control. So prospective cohort, simple. You recruit 100 women, easy with the examples. 50 without using HRT are bloody trains. $100 women, 50 using HRT, 50 not on HRT. You follow up the patient 5 years. How many breast cancer in those groups? Good. Okay. Simple. Okay. Simple. We have nothing, confusing here. Yeah. You start with a 50 with HRT, 50 without HRT. 5 years. How many got cancer? How many didn't get cancer? Case control is the other way around. You go to the hospital archives. You select 100 case notes. 50 without breast cancer because it's called cases. Cases means cancer, means real disease. And control means no. You review the notes, go back in time, call the patient, call the GP, and see how many patients was using HRT or not. So you start with the cases and end with exposure. Retrospective cohort. You go to the hospital again. This time you select case notes again. Case notes, but you will not select case notes with cancer, no cancer. You select case notes with exposure and no exposure. Cohort means you start with the exposure, no exposure. But because it's retrospective design, you have to do this with or via the case notes of the patient, not on the real patient. So you review the notes to see how many developed breast cancer. Do you see what I mean? This is called retrospective cohort study. This slide will explain what I mean. This one. This is the very famous diagram. You can Google it, by the way. I got it from Google. So, in the first one, the exposure is not known, yeah? And you're here. You're here at some point in time, okay? You have case notes with the disease, case notes with no disease. You go back to time to study the exposure, whether they exposed or not exposed. Some disease patient will be exposed, So we're not the same for the other one. Yeah? Is that clear? Clear, yeah? And for the prospective cohort study, yeah, prospective cohort study, you start with the exposure like HRT, no HRT. You follow up in time. You follow up in time till you find out how many patients got cancer or no cancer. Retrospective cohort, see that's the third one. Where are you? You are here today. You are here today. You don't know about the disease, but you know about the exposure from the case notes. So you go back in time, you choose the case notes with the exposure, no exposure. Okay, and you study the case notes, you study the patients, you found the patient, you call the GP, you review other records in other hospital. Did that patient named so-and-so with the case notes number so-and-so develop the cancer at your record or not? And the same for non-exposed patients. Okay, case control, you start with the outcome. Cohort always start with exposure. This is either in real time or through case notes, which is retrospective. The case control only through case notes or hospital records. Is this clear, guys? You see what I mean now? Do you have any point of confusion? This is very important for you to clear today. When you're following retrospectively, we have the outcomes. No, we don't know the outcomes. We don't. Sometimes, let me explain. Sometimes your hospital is not a tertiary case hospital. All you have in your hand today is some case notes with some patient in your hospital that inserted Mirena, for example, at some time. You need to, like 10 years ago or so, you go to the hospital archives of 10 years ago, you get all the case notes of 10 years ago and choose the case notes of Mirena, no Mirena. Then you do your research, okay? You ask the patient, if you have a phone number of the patient, you contact other hospitals. Did this patient develop endometrial cancer or breast cancer? No. Another hospital, did this patient develop endometrial cancer? No. And the same for the non-exposed. So you start with the exposure. Again, every time you see the word cohort, you start with the exposure. Every time you see the case control, you start with the outcome. Okay? Retrospective cohort is very rare in medicine. Okay? And it rarely turns up in the exam. I know you're tired. I'm tired as well. I hope I meet you again at some point. Some examples. Okay, so this is, we need to solve some questions and then it will be end today. So Dr. Anusha, could you please bear with me? Read this example. You go to the hospital archives. You select 100 case notes, 50 with history of HRT. 50, sorry, this is HRT. Sorry. 50 without HRT. This is the exposure, yeah? So you go to the hospital, you get two kind of case notes with HRT, case note with HRT. Now you need to study if those patients developed cancer. Okay, you found the patient, you contact other hospitals, and you see how many got cancer and no cancer. At some point, you are here today, but you've seen things in the past. Okay, like making a circle, like time travel. You start with the exposure. In the case control, You start like, makes sense. You start from the outcome and back to the exposure. Yes, I know it's confusing, but this, believe me, this picture, it does it all. We need to solve questions, guys. It'll be clear for you, okay? I know things may not be perfectly, good today. I'm really sorry about that. So one last slide. All cohort studies starts with exposure and ends with the disease. Prospective cohort study will start fresh with exposed and non-exposed, and we will wait for the disease to occur. This is perfect prospective cohort. Retrospective cohort, we review the case notes of the exposed and non-exposed to see how many developed the disease later on using other records. Case controls straight backwards. We review the case notes of the disease and control. This is the difference between this one and that one. This is your start point to see how many was exposed and not exposed. Question. I can't read. I need to get some water. So please, could you please read the question properly, read the responses, and tell me what you think about the answer. Thank you. Okay, what do you say, guys? What is your, so tell me, what do you think? Hey, perfect. Do you have any, confusion about this? So you're investigating a relationship between egg consumption and heart disease. Okay, a group of age and 6 matched patients. So I told you, it's important to know the matching case control. So you match the cases of age and sex to make egg consumption the only thing. You start, yes, Dr. Zia, perfect. You start with the heart disease and not, basically this study started like this. That researcher went to the hospital archive, got 100 case notes of heart disease patient and no heart disease patient, okay? Or maybe admitted to the hospital. Well, they selected the controls matched to the cases, same age, same sex, all males or all females, or above 50, or same body weight. And study the effect of egg. Do you eat eggs? Do you like eggs? Do you eat eggs a lot? No, yes, or something like this. This is called matching case control. You study with the outcome, back to the exposure would be case control. Good. Next question. Okay, tell me, next question. About to finish, just a few slides left. That's pretty simple one, straightforward. So you start this time with exposure, certain solvent and cancer. All employees at the factory. Dr. Parveen, why is it case control? Why? You start with an exposure. Your start point with an exposure of industrial solvent. Yeah. So you got 100 factory employees without exposure, the other 100 with no solvent exposure. You follow up those people over the period of 10 years. And at the end of the day, yeah, cohort study, exposure, disease, or death. Cohort study. Good. Perfect. You are perfect today. You survived me, and this is a miracle. Good. C, next question. A survey was conducted for all nurses. Yeah, that's a very good point that you did. You always ask yourself, did I start with exposure or did I start with the outcome? Did I study the effective time? So you survey conducted. This is a tricky one. Please read the question properly. The survey was conducted of all nurses, okay, employed at a particular hospital among other packages. The question asked about the grade of nurse and whether she was satisfied. See, did you study? Ask yourself, did you study the effective time? No, we didn't study the effective time. So this is a cross-sectional study. Most of the survey studies will be cross-sectional studies, but you need to read the question properly. Perfect, guys. Okay, evaluating a new PAC school patients with lower back pain were randomly allocated to either a new school or to conventional occupational therapist. After 3 months, there were questions about the back pain and observed lifting weight by independent monitors. This is the purpose, straightforward. You see those words that I explained: random allocation, allocation concealment, okay, a new PAC school. Okay. D, this is a perfect randomized controlled trial. It is clear, straightforward, yes? Perfect. This one is tricky, really tricky. You need to think about it very, thoroughly. Read the question and tell me what you think. We're almost finished. What do you think? Oh. Do have advice for you guys, okay? I know this question, actually, I spent some time, thinking about it. I didn't get it, just like this. I spent some time thinking about it. Could you please, okay, follow my advice? You see some confusing words, something that we're not used to say in the research field, yeah? Could you please, replace the confusing words with some much more, simple example, okay? Like here, the exposure is the new trial system. This is the exposure. And the outcome is the waiting time. I wouldn't do it like this. I would do the new exposure like a new drug, for example, and the waiting times, which is the outcome, I'll strike it off. I write like literature. So a new medication, read like this, should read like that. A new medication has been set up at like local hospital to evaluate the blood pressure. So the blood pressure, okay, of the patient was measured for 6 months and compared with the blood pressure at a comparable nearby hospital, which used an older medication. Do you think, is it much easier now or not? Tell me. Is it easier now or not? First of all, you're doing experiments or you're doing observation. You intervene, yeah? You intervened, yeah? So it's not because you're trying a new medication. So it can never be observational. It can never be case control, cohort. It can never be nested case control, retrospective. Can never be any of that. So we left with those. You're doing experiment, yeah? We're trying new medication, new bloody medication to an older bloody medication. Yes? Did you do any randomization? Did you control which patient would take this one or that one? Or do you let it to the patient? You let it to the patient. So this will be quasi-experimental design. It's tricky. In the exam, if you have an EMQ with statistics or EMQ with MRCOG with the statistics, or MRCOG with study design. You'll have 2 easy questions. They're actually set of 3. Is that correct? Set of 3 questions per one MRCOG. So you have 2 easy questions and 1 tricky like this one. I told you a trick today, many tricks today. One of the sensitivity and specificity, the high false negative, low sensitivity, and other things. And this is a tricky one as well. Please, a 95% confidence interval. You strike it off and say you're 95% confident that the range between this and that, if it crosses 1, so be, not significant. And this is the last one. Strike off the confusing words. Make a simple example for you. Okay, you'll get to the right answer. Okay, so this one I'm talking about. Okay, last 2 questions, question 19 and question 20. Regarding RCTs, which of the following is false? Pretty easy one. Which is false? Straight ahead. When talking about the false, the except, they're not observations. So yes, they got the standard, they're the best of the best. The Cureme à la Cureme, as the French says. Okay, the intervention under investigations is compared to the standard treatment. That's correct. The intervention under investigations compared to the placebo. Sometimes they compare with the standard, sometimes compare with the placebo. In such studies, the patients are allocated in random fashion. Yes, if had it not like that, that'd be quasi-experimental study. Okay, had it not been like that, it would have been quasi-experimental study. Last question, question 20. Result of study, risk factor cesarean section. This is a tricky one. I swear, this is the last question. The next slide will be the bye-bye. So, it's not well inscripted, okay? It could have been written in a better way. So, the result of study, risk factor for cesarean section. So, this is the outcome, cesarean section. We study different risk factors, exposure or effect of the cesarean section. So, obese show the spontaneous onset of labor had relative risk for cesarean section 0.76. What does it mean that spontaneous labor relative risk is 0.76 to cesarean section? Is it protective or increase the rate of cesarean section? 76 means is it protective against cesarean section or increase protective? Perfect, because it's less than 1. And the use of misoprostol for the induction of labor had relative risk of 2.8. 2.8. This table will look like this. We have cesarean section, yes or no. Misoprostol, yes or no. The risk of exposed of the risk of unexposed of the misoprostol will be 2.7. And for the spontaneous induction of labor, exposed and not exposed will be 0.7. So what will be your answer? So obviously here the misoprostol has increased the risk of cesarean section of the outcome. Yeah. If you're using misoprostol, this is what it tells. This is what can be interpreted like this way. The use of misoprostol, yeah, puts the patient at 2.8 higher risk of getting cesarean section, and having spontaneous labor will put the patient at 25% less risk of getting cesarean section. So is this clear? Yes, this is the correct answer. Perfect, all of you. Is this clear, sir? Is this clear, my dear colleagues? Thank you. Finally, you survived me today. Thank you so much. Thank you. I'm really happy of you today. Thank you so much for listening.
Sir, can I ask one doubt only to you before leaving?
Yes, sure.
Thank you so much, sir. This is really indeed a very nice session. So I want to ask the 2 questions only. That whenever we start the randomized control trial, actually the many